Everybody. I want to welcome everybody to this roundtable, the first one we've ever done that's completely on the internet via video. We tested out this capability yesterday. It looks pretty slick, but I would anticipate a few hitches. But everybody, I think we can handle this if we just kind of follow the rules. And so let me quickly out some of the rules here. First of all, if you'll take a look at the circles on the bottom of your screen there, if you have a mouse and you get your little arrow up and going, there are two icons on the far left. There's a microphone and a video. If you're in attendance as a member or a witness, keep your video unmuted. I just muted mine, just unmuted it there. So kind of see how that works. Do not touch your audio. You are automatically, everybody's muted until it's your turn to speak. And we're doing that not to be cruel, but just because it makes an awful lot of sense in terms of being able to not have a bunch of chaos during this roundtable. Again, because of that disruption, sensitive multiple microphones, don't touch that mute button. If you'd like to speak at another time, there is on the attendee list at the very bottom, if you take a look, it's very small, but there's a little hand. There's three little squares and a little hand. If you click on that, I'm clicking on mine right now, that will signal either the witnesses or me that you want to make a point. Certainly, I don't have a problem with witnesses doing it. I'm hoping members do it sparingly. Again, this is not going to be like a normal hearing, so not quite the same kind of free flow that we normally have. And what I would urge all the members is to direct your questions at a particular witness. Again, it's going to be pretty hard to have this wide open. So if you got a particular question, ask it to a particular witness or possibly witnesses, but be very specific. And we are going to be very mindful of the time. I want both the senators and the witnesses to be, watching that 7-minute clock run down. The favorite technique of senators is to ask about a question that requires about a 5-minute answer right at the 6:59 mark. Don't really want to allow that. We can take those types of questions under advisement for questions for the record. So with that, Dan, if you can quick put up, I've just got 4 little charts, should really surprise nobody. But I just want to start out with some basic information, because what this hearing really is, from my standpoint, all about is, as we develop data, let's face it, when COVID, when we found out about that, brand new virus, nobody ever heard about it, pretty darn scary. You see folks in China in moon suits. And so it's that fear of the unknown that is driving so much of the policy right now. And I have not been critical of really any policymaker who's had to make very tough decisions with very limited information. But as we're gathering that data now, and that's what this hearing is all about, is we should take that new information, that new data into account in terms of how do we modify our policy, as well as what I've been advising for quite some time is we have to look at the totality of the harm being done, not only just the tragedy from a standpoint of lives lost and lives destroyed, but also the economic destruction, the human toll that is taking as well. So I've just got 4 quick slides, just some basic information to kind of try and keep everything in perspective. The first one is the one on the screen, causes of death for 2018. You notice 2.8 million Americans died that year. That's pretty typical. It's almost 8,000 people per day. I think the largest number of per day deaths for COVID is slightly over 2,000. So you can understand how significant an issue, the significant tragedy that COVID really is. Next slide. This is just the 9-year history off the CDC website of seasonal flu. I think it's important to point out the magnitude of that problem. I think the figure is only 40% of Americans get vaccinated for this. The vaccine's not 100% effective. And you can see how many Americans die on an annual basis over the last 9 years. In total, 337,000 Americans have lost their lives due to seasonal flu over the last 9 years. That's an average symptomatic case fatality rate of 0.13%. You can see, look in the past years, kind of the lowest level is about 0.1%. A really bad flu season is almost 0.18%. I think those numbers are important to keep in mind as we take a look and we eventually find out what not the case infection rate is with COVID, but what is the actual infection fatality rate, which as the denominator grows and that infection fatality rate decreases, hopefully some of the fear will be reduced. Again, I'm not saying the fear is not irrational. It absolutely is legitimate. But in order to really regain our economy and open it back up, we do need people looking at this from a proper perspective and hopefully with effective therapy and cure. And we're going to have Dr. Kory on to talk about some pretty hopeful signs in terms of therapies in the hospital. Hopefully we can also bring down that fear level so people can go back to a more normal type of life. But you can see 337,000 deaths over the last 9 years just due to seasonal flu. Next. This is just, and these are up-to-date figures as of this morning. So here's a state and territory comparison. Unfortunately, for New York, it leads the pack in terms of number of cases, in terms of number of deaths, in terms of percent of the population that are known cases, 1.7%, percent of deaths of the population, 0.13%. The lowest percent of population in terms of cases is Hawaii and Montana at about 0.043 compared to New York's at 1.7. And in terms of percent deaths, there are a lot of states, fortunately, that are only 0.001. On average, America is about 0.36% of the population is reported as a case, and 0.02 of the population has actually died from COVID. And then the final chart, Dan, these just country comparison. I've got 12 countries on here that I've been tracking pretty much on a daily basis. I'm going to throw Russia and China out in terms of actual comparisons because I'm quite honestly not sure how accurate their reporting is. But I think the other nations, and let's face it, everybody's going to have different standards on how they report these cases and how they collect information. But I think it's important to point out when you take a look at the cases as a percentage of population, the United States ranks number 3 in terms of worst, in terms of highest percentage of the population that's been infected, but we rate 7th when it comes to percentage of deaths or percent of population the deaths are at 0.02. I want to point out Sweden because Sweden definitely took a different approach to responding to COVID. They basically took the approach of we will quarantine the sick, we will protect the vulnerable, and the rest of us will basically go about our lives, obviously following the guidelines of social distancing and sanitizing, personal hygiene, that type of thing. And again, these numbers, we don't know where they'll eventually turn out, but Sweden, in the scheme of things, is not doing that badly. In terms of percentage of their population that have a confirmed case, they rate 8th at 0.26. And in terms of percent of their population that have died, they rate 6th on this list out of these 12 countries at 0.03. So again, that's just some basic information. I tried to get that to all the witnesses and senators just to have, to again, put all this in perspective. With that, I'll turn it over to Senator Peters, my ranking member, for his opening comments.
Thank you, Mr. Chairman. The coronavirus pandemic has certainly profoundly altered our world. It's putting millions of people out of work, threatening the future of small businesses, exposing serious inequities in our healthcare system, and is taking the lives to date of more than 71,000 Americans. And like so many of us, I'm ready to start getting America back to work, but we need a clear plan, backed by science and by data. That will give us a roadmap to safely reopening our economy in stages. While cases in some parts of the country appear to be plateauing, we know that there are other communities that are experiencing rising numbers right now. We currently don't have enough tests to fully understand how many people have contracted or succumb to the virus. We are still struggling to get enough masks, gloves, and other personal protective equipment to our frontline workers, and we don't yet have the supplies needed to prevent a resurgence of this virus. We need a robust contract tracing plan to identify possible exposure to coronavirus and prevent further spread that could result in another wave of cases, hospitalizations, and unfortunately, tragic deaths. We need to protect and grow the capacity of our hospitals to deal with these localized outbreaks, and we need to back production of life-saving drugs and medical supplies we need to take back that production from China. We need to develop and deploy a vaccine to inoculate Americans who have not contracted the virus. And we need clear data and metrics that are backed by science to tell us what is working and what is not. And we need a push to use these best practices to help our small businesses out so that they can keep their employees safe and their customers' confidence. This critical information and the lessons we have learned will help create a plan for how we can safely reopen. Without this data-driven plan, we risk undermining the progress that we have made and repeat the unbearable loss of human life and economic shock that we are currently experiencing. Despite all this hardship, I'm encouraged every day by the workers and the entrepreneurs in my home state of Michigan that are finding ways to keep their workplaces safe and, as we speak, are retooling their businesses to meet the needs of frontline responders. I've talked to many of them over the last few months, and they all are saying they need clear guidance by reliable data to back up their actions. We also must remain focused on the unequal impact of this virus and how it impacts communities of color. In Michigan, Black residents make up 13% of the population, but represent 40% of the deaths from COVID-19. This disparity is rooted in systemic inequity, and we must change our plans in response to the data and protect these communities, not simply accept the inequity of the inevitable. These decisions are a matter of life and death, and we cannot accept tens of thousands more coronavirus deaths as unavoidable. Just as we can't accept the reopening of our economy while minimizing risk isn't possible. We must have a clear path that provides people with guidelines that are backed by science to help us reopen. I look forward to today's discussion and to continuing to work with all of my colleagues to ensure that we're taking the appropriate steps necessary to allow us to safely reopen our economy while protecting our most precious resource, the American people. Thank you, Mr. Chairman.
Well, thanks, Senator Peters. I'd really like to thank all of our witnesses for the time you've taken out of your day just to participate in this, but also the time you've spent, first of all, speaking to these issues. I think all but one of you I've seen on some TV show in the last couple of weeks, but you've put your lives and you've done a lot of work to try and educate the public, and I truly appreciate that. The one outlier will be our first witness, Dr. Pierre Kory. I just spoke with him last week. He's affiliated with the University of Wisconsin-Madison, but he's a New Yorker, and he's currently on the front lines in New York. And the reason I wanted to put him first is to give us a little bit of hope. What he is talking about in terms of effective therapy once individuals have been hospitalized, I think is very encouraging. And I wanted to give him enough time to kind of speak to that before we kind of open up into the sort of the main purpose of what this hearing was all about, which was really taking a look at the data and taking a look at the policy choices and decisions that we've made and that we need to make based on what that information, what that data tells us and instructs us. So again, our next witness is Dr. Pierre Kory. He is the Chief of Critical Care Service and Medical Director of the Trauma and Life Support Center and Associate Professor of Medicine at the University of Wisconsin School of Medicine and Public Health. He is board certified in critical medicine, pulmonary diseases, and internal medicine. He previously served as director of the advanced courses sponsored by the American College of Chest Physicians. Dr. Kory received an MD at the St. George's University School of Medicine. Dr. Kory.
All right, yeah, thank you. I believe I'm unmuted. So thanks for the invitation. I really appreciate the opportunity to talk about COVID. I do want to start out by saying that I'm speaking today as part of a group. I have bonded with 5 colleagues. They're some of the most well-known and highly published and most impactful critical care experts in the world. And I do want to make sure that I mention them. So one is my colleague, Dr. Paul Marek. He's from the Eastern Virginia Medical School, very well known in our specialty. Also, Dr. Umberto Meduri, who's from the University of Tennessee in Memphis. And then also Dr. Joe Verone in Houston, and then Dr. Jose Iglesias from Hackensack. Now, the five of us, we came together early on in COVID, and we've been trying to figure out this disease. And I got to tell you, we came up with a protocol, and I want to talk about that protocol, but with some other issues that I think the healthcare system needs to be aware of. So first of all, let me just tell you about some of the results of our protocol. So members of our group have now treated in excess of 100 hospitalized patients with our treatment protocol. And we're going to report that nearly all survived. The two that died were in their 80s and had advanced chronic medical conditions. None of the patients had long stays on the ventilators, none are ventilator dependent, and most of them had short hospital stays and were discharged in general good health. And so I'm going to say that is good news. Many people are going to be skeptical and ask about that. But let me talk about a little bit more about why we are seeing that. So the first thing is I just want to say how troubled we were. I appreciate your comments, Senator Johnson, about how we're all doing the best we can with the data we have, and so it's hard to point fingers. But I have to say that we're a little bit we are dismayed by the lack of a proposal for an effective treatment protocol. There's three critical things that we've seen over the last month that we really want to talk about. So number one. And again, I do not want to diminish the value and the expertise of our national healthcare societies and international healthcare societies like the WHO and the CDC. However, I think those are bodies that are built for peacetime and not for war. And we're at war right now with this virus. And one of the main issues that we've seen is that they initially came out, all of the national healthcare societies came out with recommendations that focuses on supportive care only, which is generally you give Tylenol for fever, you treat symptoms, you might give a little hydration, nutrition, and you give oxygen and ventilators for support when they can't breathe. And that's reasonable for viral syndrome, but this thing is different, number one. Number two, that strategy is failing. I don't think I need to spend a lot of time showing how badly that's failing. The mortality and morbidity rates of this disease are unprecedented. I've been doing critical care for a decade and a half. I do not see mortality rates associated with any severe illness that I see in this one. Supportive care is not working. We're just trying to put a call out to the world to rethink this supportive care only strategy. So that's one major concern we've had. The second is we want to call attention to the world to what we think is a tragic error in analysis of medical data. And that is the fact that all societies from the beginning of COVID have advised against the use of corticosteroids in COVID-19. We think that is a fatal and tragic flaw. And I will tell you why. One of the members of my group, Dr. Umberto Meduri, who's probably the world expert on corticosteroid therapy in critical illness, 3 weeks ago, he published a paper along with 5 other internationally known experts. They published a paper in Critical Care Explorations, which essentially reviewed the role and impact of corticosteroid therapy in all the prior pandemics, including the coronavirus pandemics of SARS, MERS, and H1N1. And contrary to the conclusion of the reviews done by all those national societies, they showed that in the 2 largest and most carefully executed studies of all of the impacts of corticosteroid, that corticosteroids are actually life-saving in these severe viral syndromes. They showed drastic reductions in mortality in anyone who had anything beyond mild disease. You shouldn't use it early as an outpatient, but once you hit the hospital, it's life-saving. And just this week, we're starting to get even more really impressive data showing the importance of corticosteroid therapy in these syndromes. So, for instance, just this week, Surin Dragici, he's the CEO of Advaita Bioinformatics. And this is fascinating stuff. And this is about as cutting edge and futuristic medicine that you can imagine. But they have this sophisticated artificial intelligence platform called iPathway Guide. And what they did is they cultured human cells and they infected them with coronavirus. And they were able to analyze the genes that were activated by the coronavirus. They were able to do this with multiple viruses. And what they saw is that in the coronavirus cell types, the amount of the types of genes that were activated, they were able to match that against medicines that suppress the activation of those genes. And the one drug that they found that perfectly met the ability to counteract that gene activation was methylprednisone, which is a corticosteroid. At the same time that they did that, Dr. Mayur Ramesh at the Henry Ford Hospital, he's an a transplant infectious disease expert and immunologist. He implemented a methylprednisolone protocol. Their study just came out this week. And what they showed, and I talked to them in personal communication, is once they started using methylprednisolone, their needs for ventilators went down, their mortality went down, their reportedness in a study that's right now just a pre-publication, but in over 200 patients, they saw dramatic effects. He said the entire environment changed. There was less codes, less need for ventilators. Their ventilators peaked and decreased. So they came out of a mass casualty environment to a much more controlled condition. And then right now, we're also getting word that there's a paper under review from our colleagues in Spain, critical care experts, all of them, who are now reporting that when they use methylprednisolone therapy earlier and longer than in the Henry Ford study, they're showing absolutely dramatic reductions in mortality. So those mortality rates that you're seeing, we think that there's a really strong answer to that, and we need to change our treatment strategy, which was one where we did not use corticosteroids, which we think are critical, and we want to use them. You know, again, this is the standards of medical evidence have changed a little bit in this crisis, and so I'm going to use some Facebook posts. But these were posts that were posted anonymously by doctors who are in the middle of this surge. And this is what one of them posted 2 weeks ago. This is a hospitalist from Southeast Michigan, and he wrote, "We floundered for 2 weeks. Lots of codes, intubations, and death. Maybe 15 discharges. We started steroids and discharged 250 patients. Less intubations, less codes. And the ones that ended up on a ventilator, not as serious. If they have chest x-ray or CAT scan changes, start steroids. If they are hypoxic, start steroids. If they are ambulatory and hypoxic, start steroids." This completely changed our trajectory. Steroids are a game changer. This critical efficacy is being noticed more and more around the world. We're seeing it pop up in new protocols and guidelines. Another post from a doctor in New Orleans who also got inundated in the surge. They found, he writes, "I'm here in New Orleans. Since we started using steroids, we were able to free ventilators and get elderly patients out of the hospital without needing a ventilator. Patients that were obviously crashing quickly, who we had to have end-of-life talks with, were able to walk out of the hospital. At no point did any of our patients worsen because of steroids. These patients shed viruses 4 weeks later with or without steroids. The virus doesn't kill anybody, it's the inflammation that does." You know, so those two things that I just reviewed, which is one, the fact that the supportive care only is failing. Two, the lack of steroids may be a critical absence in the treatment strategies of these patients. And then number three, the other thing that we've seen all around the world in many institutions, in medical journals and editorials, is this constant cry for randomized controlled trials or prospective trials. Listen, we in our group, we all know the critical need for data and trials, but we think there's an overemphasis, and we're forgetting some of the ethics of doing research in a pandemic when patients are dying and they're very sick. And I want to remind us of a few ethical principles that the world has agreed on. So number one, the Declaration of Geneva of the WMA, which is the World Medical Association, binds the physician with the words, "The health of my patient will be my first consideration." Number two, the International Code of Medical Ethics declares that a physician shall act in the patient's best interest when providing medical care. And then most importantly, this is where everyone's getting confused, is that this idea that what we're doing is unproven or experimental therapies. I want to call particular attention to Article 37 of the World Medical Association Declaration of Helsinki, first approved in 1964 and most recently approved in 2013. And in that Article 37, which is titled Unproven Interventions in Clinical Practice, it reads, and I paraphrase, "In the treatment of an individual patient, where proven interventions do not exist, a physician may use an unproven intervention if in the physician's judgment it offers hope of saving life, reestablishing health, or alleviating suffering." You know, having said that, let me just talk about what our group did. And I'm sorry if I'm going a little bit over time, but this is what we did. So myself and Dr. Marek and Dr. Berduri and Dr. Iglesias and Dr. Verone, we got together early on, and all we did is talk COVID 24 hours a day. We exchanged emails and papers and clinical discussions. Probably my biggest contribution to the group is that I am a New Yorker. I've trained with, I've been trained by, and I've trained almost every person in every ICU in New York City. And from the beginning, while I was in Madison preparing for the surge, I got to talk to them each and every day. And the accumulated clinical experiences, the impressions, the responses to different treatment strategies, we all got to observe. And we convened a group and we came up with a treatment protocol. It's based on decades of our experience at taking care of patients, our research, as well as hundreds of publications. What we noticed was three things that I think people are not recognizing, is that the way that this virus is killing people and causing all these organ failures, there's three major pathologic processes that we're seeing, which is this state of extreme hyper and dysregulated inflammation. Some people are calling it a cytokine storm. That's number one. Number two, we're seeing hypercoagulability with frequent and excessive clotting. And number three, we're seeing this outsized hypoxemia, which approaches to treating that have sort of been evolving, but I think we failed in the beginning. And so based on those three processes and based on our knowledge of therapies and therapeutics, we came up with what we calling our Math Plus protocol. It's on our website. It's COVID-19criticalcare.com, but I'm going to go through it really quickly. Number one, the three critical medicines is methylprednisone. I just gave you some of the evidence and some of the rationale why that's critical. We know it worked in SARS, MERS, and H1N1. And the fact that we're not using it here, I think, is causing some of this needless death. So methylprednisone, number one, it's a powerful anti-inflammatory drug that we use to suppress the immune system and prevent organ damage. This condition in COVID-19, which is the cytokine storm, a corticosteroid is the standard recommended treatment accepted around the world for cytokine storm. Ascorbic acid, although known as vitamin C, everyone dismisses it as a vitamin. Those of us who use it and know its physiology and its potency, it's not only a vitamin, it acts as a stress hormone in fighting off infections. It's critical and has synergistic capabilities along with steroids. And so we strongly promote that. It prevents the development of leaky blood vessels within the lung, and it avoids the development of lung failure. It should always be used when paired with corticosteroids. Heparin is another one. It's a blood thinner. We're seeing excessive blood clotting. Almost all centers and institutions around there have promoted the use of some amount of blood thinners. Some are more cautious than others. Some are more aggressive than others. But we all recognize the critical need. And then the last thing is what a lot of us got wrong. I'm going to say the University of Wisconsin, we didn't. I'm going to toot my own horn here, but we avoided the early intubation. Early intubation with these patients is harming them. The machine makes the disease worse. And so we should try to avoid intubating until last resort. And as we do that, we are seeing that we're able to alter the trajectory of these patients away from the ventilators, and we're seeing lives saved. So I'm just going to summarize by saying our treatment is not unique. We're starting to see it pop up in centers and protocols in countries around the world. The most recent Italian guidelines were extremely aggressive. They're mandating an overall focus on treating inflammation with tocilizumab and mandatory steroid use early on in the disease. They're saying to do it as soon as someone's oxygen level drops. And this is what I want to say. This is the last tragedy. And I know that probably what I've said is a little bit heated. I'm emotional, but this is absolutely a calamity that's going on in medicine. But I've been in New York City for 2 weeks trying to treat these patients with COVID. Either I've been inundated with patients who are chronically on the vent who are dying of end-stage fibrotic lung disease, or I'm seeing patients who are crashing into my ICU. But as opposed to a month ago where they were coming in with these mild abnormalities on chest x-ray and maybe mild abnormalities in their oxygen intake, now we're seeing floridly abnormal x-rays with very advanced disease. I'm throwing the book at them and it's not working. I have to emphasize that the timing of initiation of this therapy is critical. The world needs to know this. What happened here in New York is that initial surge caused so many terrible reports of patients being unattended to, running out of resources, not enough physicians and nurses, and now the population is scared. They're not coming to the hospital early enough. And now when they're coming, they're so far advanced that the medicines don't work as well. And so we need to get the word out that, things are better on the ground. We're definitely much more stable in the hospitals. We're much more resourced. We're regrouped. We're ready to take care of patients, but the patients have to come. If they wait at home with these symptoms, we're not going to be able to save them. And so I just want to finish by saying, finally, our group and what we've tried to do is put together an effective, sound, physiologic, and evidence-based protocol. And we've been trying to disseminate it. We've sent it. It's gone to the White House 3 times now. A month ago, it was given to a member of, I think, Kushner's team and brought it to the White House. They apparently liked it. However, they got pushback from the NIH and the CDC, who I think were cautious on the steroids. And then 2 weeks ago, Dr. Marek was interviewed by Newt Gingrich, a former speaker, Newt Gingrich, who also brought it to the White House. We still haven't heard. And then this week, our protocol and our group's efforts were published in the American Spectator, and the editor of the American Spectator also brought it to the White House. We still haven't heard anything. We do think that we need to develop a national effective treatment strategy. And with that, I think I'm just going to end there and just say we're experts in our field. This is what we do. We know how to take care of patients. Let us take care of these patients. We know that these medicines are sound. We know the safety profile. Everything in our protocol is safe. FDA approved, has been used for decades. Yes, that's off label, but we do off label stuff every day. And with that, I probably took too much time. I'm done. Thank you.
Well, first of all, thank you, Dr. Kory, for just being a doctor, for your passion. I can tell you now your protocol has been sent to the White House 4 times. I sent it to Mark Meadows today with the text that I pray somebody in the White House will pay attention to this and give it very serious attention. So again, thank you for that. Again, thank you. Our next witness is going to be Dr. David Katz. Dr. Katz is the president of the nonprofit True Health Initiative, CEO of Diet ID, Inc., and a board-certified specialist with 30 years of experience in preventive medicine and public health, having trained and later taught at Yale University School of Medicine. Dr. Katz is the founding director of the Yale University's Yale Griffin Prevention Research Center. He received an MD from the Albert Einstein College of Medicine and master's in public health from the Yale University School of Public Health. Dr. Katz.
Senators, I greatly appreciate the privilege of addressing you, the opportunity to share my perspective. I deeply regret doing so without recourse to a professional haircut. If someone had told me I was going to be addressing a committee of the U.S. Senate and doing so sporting my hairdo from 1978, I'm not sure which of those two things I would have found harder to believe, but here we are. I'd like to make 5 quick points about COVID, and I'll quickly note that I'm addressing this primarily as someone schooled in epidemiology, public health, scrutinizing the global data and the data here in the U.S. But I did volunteer in New York, did several shifts in an emergency department in the Bronx. This was part of the Montefiore system, and Dr. Kory, you'll be pleased to hear everything you just mentioned was standard procedure. When I was there 2 weeks ago, it had not been the week before. Steroids were being used routinely, apixaban was being used routinely, and on it goes. So the word is getting out. Whether or not the White House got the memo, others have. So the first point, this is different diseases in different populations. So we heard about the population landing in the hospital, needing intensive care. But the global data clearly show that elderly people and people with a significant burden of prior chronic illness are at high risk of severe COVID infection, life-threatening infection. But the global data showed at the very beginning and appeared to show to this day that 98 to 99% of all cases are mild. Younger people, certainly people under 50, maybe under 60, people free of major chronic disease like heart disease, diabetes. This tends to be a relatively mild infection and may often be asymptomatic. Mr. Chairman, you showed us the data out of New York and talked about the fatality rate there. But a seroprevalence study in New York showed that maybe 20% of the population of New York City and perhaps the whole state has already had this infection. That would be 4 million people. And when the denominator swells to that degree, the percent of severe cases drops precipitously. And it's actually quite interesting that 20% is the same number we got from the Diamond Princess cruise ship. And maybe a significant portion of the population is just natively resistant to this bug. But it's different diseases in different populations. There's a high-risk group, elderly, chronically ill. There is a low-risk group, younger, generally healthy. Second point, from the start, it's been clear there were 2 ways for COVID-19 to hurt people, to damage health, to ruin lives. One was by infecting them, but the other basically was the unintended consequences of our interdiction efforts. If we were protecting people who didn't need to be protected from this virus because it wasn't acutely dangerous to them, then causing them to lose their livelihood, putting them in a position of food insecurity, potential poverty, was more likely to hurt them than the virus. I think a humanist, a public health person needs to look at that and say, both ways that this situation can hurt people are bad. And that leads to my third point. We really need to have one national policy objective, and it has nothing to do with trading lives against dollars. That objective is total harm minimization. We acknowledge that people can be hurt by losing their jobs, and that hurt reverberates through public health in something we call social determinants of health. Food insecurity hurts people, desperation hurts people, depression, addiction. We've seen spikes in everything from gun sales to domestic violence to suicides since the advent of this pandemic. And those are real families, those are real people. All of that warrants our attention too. And by the way, it's not clear how much of the toll of COVID in New York, in the United States, we mitigated with our interdiction efforts, because we may have closed the barn door after all the horses were out. It seems clear now that COVID was circulating in the United States before we knew about it. We have evidence to suggest from seroprevalence studies that millions and millions of people in New York and around the nation have already been infected. So a lot of what we're seeing may be what we would have seen even with significantly less draconian interdiction efforts. The other thing we want to do, of course, is restore key elements of our society, because those are crucial to services, goods, and supply chains, and ultimately become rate limiting in terms of people's health. We also need to worry about people staying away from the hospital who have other important conditions because of the fear of going where COVID is that Dr. Kory described so beautifully. And then one other critical issue that I think is often overlooked, and that is we do need an all clear. Frankly, I think about people like my parents who are 80 years old. My mother worries that she could get COVID and die because she's in the high risk group at that age. She also worries, though, if we're on an indefinite timeline waiting from a vaccine, that she could die of something else before she ever again gets to hug her grandchildren. So I do think important segments of the population are waiting on a plan back. And the most likely proximal route to an all clear is herd immunity. And that doesn't mean putting people in harm's way. It means risk stratifying the population. So we're able to say who can encounter this infection safely because they're overwhelmingly likely to have a mild bout of it, get over it, make antibodies. And it is fairly clear from the global data, we do make antibodies, we do become immune. There was some communication on that topic that I think was a bit misleading. Point number 4 is we need data to inform a risk stratified approach back to life as we knew it before, protect the vulnerable, but allow many of us who are not prone to severe infection back. And in order to inform a risk stratified approach, 2 things. First, we don't need millions of tests. We need a representative random sample. That could be 20,000 people, 30,000 people, 50,000 people. We could make it a fairly big and robust number. But as long as it traverses urban, suburban, rural, all the different zip codes, all the different age groups, all the different health status, it would be enough to extrapolate to the population of 330 million of us and tell us what we need to know. Who is at risk? Who is likely to be hospitalized? Who might need the ICU? Who's at risk of death? And for whom is the risk of COVID infection commensurate with many other risks associated just with living routinely? And I think that's a critical element. And frankly, this is something CDC does routinely, and it's the work of several days at most a week, and it doesn't require millions of test kits. And then finally, in speaking with colleagues, some of whom are joining as witnesses today, others like Dr. Mike Osterholm at the University of Minnesota, arguably the nation's greatest pandemic response expert, we do need a bracing dose of humility. Previous pandemics have fooled us. When we thought we were most of the way through the woods, we would get a second wave. We do need supplies of PPE. We do need to know we'll have hospital beds if this comes back in the fall. We need to know that the ventilators are available. So we have been forewarned. We need to be forearmed. And it is possible there will be additional waves. I'm hopeful there won't be. I'm hopeful this has actually already been quite widespread in our nation. Many people have had this and didn't even know. Many people may be natively resistant, and maybe we're well on our way to herd immunity. And Sweden is an encouraging example, but I think we could do even better than Sweden by more carefully protecting the high-risk groups and using American data to inform that effort. And then finally, there has never been a better time for a Get Healthy America campaign. The things that place people at risk for severe COVID infection are things that were taking years from lives and life from years before. Heart disease, diabetes, hypertension, obesity, these are all fixable, and they're fixable with lifestyle. We can use risk calculators to identify someone's individual risk. We can take advantage of the fixation on this condition and the acuity of concern to suddenly get people to care about those long-term risk issues, which have been a threat to people's lives, a threat to people's livelihoods, a drain on the economy, all the bad stuff associated with COVID. That was going on before, but I would encourage you to think about basically making lemonade from the lemons here. We don't just have COVID to deal with. We were especially vulnerable to a higher percentage of severe cases because the health of the nation was in peril before from chronic disease. And if we address that effectively now, we will both lower people's acute risk for COVID and create a gift that keeps on giving, a healthier America. Thank you.
Thank you, Dr. Katz. Our next witness is Dr. Tom Inglesby. Dr. Inglesby is the director of the Center for Health Security at the Bloomberg School of Public Health within Johns Hopkins University. Dr. Inglesby is also a professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. Prior to that, he was chair of the Board of Scientific Counselors, Office of Public Health Preparedness and Response at the U.S. Centers for Disease Control and Prevention from 2010 to 2019. Dr. Inglesby received an MD from Columbia University College of Physicians and Surgeons. Dr. Inglesby.
Today, COVID-19 has done great damage to our country, firstly in terms of people sickened and lives lost, and secondly in terms of the terrible economic consequences and job loss. As a sign of the speed of its spread, as of 2 months ago on March 6th, there were 200 people diagnosed with COVID-19 in the US. In the absence, as of yesterday, 1.19 million Americans have been diagnosed with COVID, and more than 71,000 people have died. In the absence of social distancing, this epidemic doubles in size approximately every week. That's the data that we have up until social distancing began. In the last month, more than 200,000 new American COVID cases have been diagnosed every week. We have a national plateau of about 25 to 30,000 new cases daily. We had more than 2,000 deaths yesterday from this virus, and the great majority of US deaths have occurred in the last 30 days. Yesterday, 33 US states reported more than 150 new cases of COVID in their states. 17 states have daily case counts that are still on the rise. On the other hand, 10 states do have a 2-week decline in numbers, which is encouraging. And states that have had 2-week declines and meet other conditions for safe reopening could be the least risky places for initiating reopening process. States reopening without safe conditions could be at risk for a rapid acceleration of cases. Our team worked with colleagues at the American Enterprise Institute to publish a report recommending 4 conditions that should be in place before a state eases social distancing. The first is sustained reduction in cases for at least 14 days. The second is capacity for hospitals to give all patients with COVID the full standard of care. The third is the capacity to test all people with COVID-19 symptoms, whether they're mild, moderate, severe. And the fourth is capacity to conduct active monitoring and quarantine of cases and their contacts. These conditions are largely consistent with the criteria and core state preparedness capabilities in the White House guidance report called Opening Up America Again. 38% of adults in the US, or 92.6 million people, are at higher risk of serious COVID infection, given their age of 65 or older or underlying health conditions. Some have called for focusing social distancing and mitigation efforts only on this high-risk group, but there are no feasible approaches to separate off this 1/3 of American adults. Most estimates of the infected mortality rate by epidemiologists and public health organizations are that this virus causes something on the order of 0.5 to 1% infected mortality rate. If this virus transmitted widely without social distancing, and high numbers of people got sick with COVID in the same period in a given city or state, there would be the potential of overwhelming healthcare facilities, outstripping available ventilators, and/or the people needed to run them. We came very close to this scenario in New York City last month. If that did happen, and there were not enough ventilators to go around for the people with COVID, the infected fatality rate, which I just noted, could go up substantially, as it appeared to do both in Wuhan and in Lombardy in Italy. It's very important to look at the experience of Wuhan and Lombardy and New York City in dealing with COVID. In each of them, this virus was rapidly able to go from being nearly invisible to causing a complete health crisis in a period of weeks. That pattern is absolutely nothing like influenza or any disease we have dealt with in modern times. In the time ahead, we have to find a way to cope with the severe potential public health toll and the severe economic toll of this virus in the US. some states are in a safer position than others to cautiously start to move ahead on easing social distancing. Any state that does should recognize that COVID could rebound sharply in the time that follows easing social distancing. And those states should track hospitalization rates, ICU bed rates, ventilator rates, and deaths very carefully and be prepared to change course if numbers substantially worsen. And leaders in those states should communicate clearly to the public that individual physical distancing measures, distancing between people, cloth mask use in public, avoiding gatherings, will all remain critically important throughout this entire period until we have a vaccine. Keeping the epidemic from rebounding and causing new waves will take collective great action on the part of the American public. Thank you.
Thank you, Dr. Inglesby. Our next witness is Mr. Ovik Roy. Mr. Roy is the president of Foundation for Research on Equal Opportunity, a think tank focused on expanding economic opportunity for those who least have it. From 2011 to 2016, Mr. Roy was a senior fellow at the Manhattan Institute for Policy Research. Prior to that, Mr. Roy was a financial analyst and portfolio manager at several investment firms. Mr. Roy writes for Forbes and has advised numerous candidates for public office on healthcare policy. Mr. Roy is educated at the Massachusetts Institute of Technology and Yale University School of Medicine. Mr. Roy.
Chairman Johnson, Senator Peters, and members of the Homeland Security and Governmental Affairs Committee, thanks for inviting me to speak with you today. As Chairman Johnson mentioned, I'm Ovik Roy. I'm the president of the Foundation for Research on Equal Opportunity, or FREOP, a nonpartisan, nonprofit think tank focused on expanding economic opportunities to those who least have it. All research conducted by FREOP considers the impact of public policies and proposed reforms on those with incomes or wealth below the U.S. median. It is for this reason that I am gravely concerned about the profound economic destruction that the COVID-19 lockdowns have caused. You know that 30 million Americans have lost their jobs, and that the CBO estimates that second quarter GDP will be 40% lower than it was at this time last year. Jobs for hourly wage earners, the most vulnerable workers in our economy, are down 60% relative to pre-pandemic levels. These are hairdressers and line cooks. They work at doctors' offices and on assembly lines. They are, in President Clinton's words, those who work hard and play by the rules. The good news is that the lockdowns have done what they were supposed to do, ensure that our hospitals and ICUs were not overwhelmed Italy style with severely ill COVID-19 patients. The bad news is that the shapers of conventional wisdom now claim that we must continue lockdowns for as long as we can't test the entire population for COVID-19 and have an effective treatment and develop herd immunity and produce a vaccine. All of this, we are assured, can take place in the next 12 to 18 months. But what if it takes us 12 to 18 years to develop a vaccine? We have never developed a coronavirus vaccine before. The best scientists in the world have been trying to develop a vaccine for HIV for nearly 40 years, and we still don't have one. Effective non-vaccine treatments may arrive sooner, but when? And is it realistic to stick 6-inch swabs up the nostrils of millions of Americans every day until that happens? The question of when is of urgent importance. Every week matters. The average small business holds less than 4 weeks of cash in reserve. For urban small businesses, it's more like 2 weeks. Some have been able to take advantage of the Paycheck Protection Program, but as you know, it is actually medium-sized businesses, not small businesses, that have been organized enough and savvy enough to maximize that opportunity. Shapers of the conventional wisdom argue that these devastating economic costs are necessary and acceptable because we must do everything possible to protect people from COVID-19. Let me explain why this thinking is flawed. First, the costs of the lockdown are not merely financial. The closure of schools has only widened educational disparities between the haves and have-nots. There is considerable evidence that high unemployment rates are associated with higher mortality, including deaths of despair. And there is a cost in lives and health among those who have been unable to seek non-COVID related health care, including unmanaged chronic disease, missed cancer diagnoses, untreated heart attacks, and unavailable organ transplants. Second, one-size-fits-all lockdowns are not based on actual evidence or science regarding COVID-19, but are instead based on fear and off-the-shelf playbooks designed for influenza, a meaningfully different disease. The risk of death due to COVID-19, as we have discussed, is very low for those under the age of 55, and yet our restrictions on economic activity apply equally to people of all ages. Roughly half the deaths from COVID-19 have taken place in the tri-state area around New York City, and yet we're treating Oklahoma, Utah, and Wyoming no different than Manhattan. According to an analysis by my FreeOp colleague Greg Gervin that we will be publishing this week, nearly half of all U.S. deaths due to COVID-19 are taking place in nursing homes, and yet we are not incorporating that fact into our assessment of the risks outside of nursing homes. Similarly, the risk of outdoor transmission appears to be much lower than that for indoor transmission, and yet many states are applying equally onerous restrictions to indoor and outdoor activity. Third, we've forgotten how we deal with risk in other aspects of our society. 100,000 Americans die of hospital-acquired infections each year, yet we don't shut down the hospital industry. 37,000 Americans die each year in traffic fatalities, and yet we don't shut down the roads. Indeed, traffic fatalities is a good mental framework for thinking about how to live with COVID-19. Instead of abolishing cars, we enforce traffic laws and speed limits and prohibit drunk driving. We set a minimum standard for car safety, but most of all, we expect individual drivers to be responsible for their own conduct and the conduct of their passengers. Something similar can work for COVID-19. Businesses can deep clean their surfaces and provide hand sanitizer and masks to their workers and customers. People can wash their hands regularly and minimize close contact with strangers. This is, in fact, what East Asian countries did after the
We lost him. We seem to have lost Mr. Roy. We'll come back to Mr. Roy to have him finish off his testimony. I guess in the meantime, we'll move on to our fifth witness, Mr. John Ioannidis. Dr. Ioannidis is a professor of disease prevention at the Stanford School of Medicine. He is director of the Stanford Prevention Research Center and a co-director of the Meta Research Innovation Center at Stanford Metrics. Prior to joining Stanford, Mr. Ioannidis chaired the Department of Hygiene and Epidemiology at the University of, I can't pronounce that one, Ioannina Medical School, and was an adjunct professor at several other schools of medicine. Mr. Ioannidis received his MD from the University of Athens School of Medicine and trained in internal medicine and infectious disease at Harvard Medical School and Tufts University School of Medicine. Sorry for all the mispronunciations, but Dr. Ioannidis.
Thank you for the kind invitation and the honor to join this hearing and to share some thoughts with our senators. COVID-19 represents a major crisis with major loss of life. There's no doubt about that. We should use the best science in a data-driven, evidence-based approach to minimize human loss from this pandemic. We need to consider both the benefits and harms of each of our policy interventions and to adjust our interventions according to continuous feedback with reliable data. Shelter-in-place and lockdown orders were justified initially when announcements declared a new contagious virus with 3.4% fatality rate and no asymptomatic infections. Prospects of 60 million deaths worldwide led to comparisons against 1918 influenza. However, currently we know that asymptomatic or mildly symptomatic infections that people are not even aware of and do nothing about are very, very common. The number of people infected are actually far, far more than those documented to date with PCR testing. The infection fatality rate is accordingly much lower than the crude fatality rates derived from dividing the number of deaths by the number of documented cases. The exact infection fatality rate will vary from one place to another, depending on whether hospitals had crashed or elderly care nursing homes had been widely contaminated or not. But in places that do not see these disasters, it is very comparable to seasonal influenza. While this is a very contagious virus and many people can be infected, to date, person years of life lost from COVID-19 worldwide is probably in the range of 100 to 1,000-fold less than the person years of life lost from influenza in 1918. At a global level, the number of person years lost this year from COVID-19 is comparable or less than that of seasonal influenza around the world. Of course, a second wave cannot yet be excluded, and we need to be very cautious about that. Its occurrence and potential magnitude can only be speculated with mathematical models, but unfortunately, models have not been successful at all so far in making COVID-19 predictions. Therefore, we need to proceed with caution in lifting lockdown and monitor the impact of any changes in policy measures with real data as opposed to just using models. The fatality rate from COVID-19 is highly dependent on age, and it is modulated by the presence of comorbidities. For children and young adults, it appears that infection fatality rate is lower than seasonal influenza. And for middle-aged adults, it is about the same. Infection fatality rate can increase sharply, however, when nursing homes are massively infected and when unprepared hospitals running close to full capacity, even on a regular season, are overwhelmed, and the infection spreads to hospitalized patients in what we call nosocomial infections. This explains the paradox, why COVID-19 is typically a very mild, benign infection, but at the same time, it also has the potential to become devastating in specific settings. While lockdowns were justified initially, their perpetuation may risk many lives. Unemployment may create more marginalized citizens without health insurance. Mental health can be affected with increases in depression, suicides, domestic violence, and child abuse. Gun sales have increased drastically. Starvation is becoming a global threat. Moreover, deaths from common chronic diseases and treatable conditions, such as heart attacks, may increase as patients avoid hospitals from fear, as interaction with their caregivers is disrupted, and as hospitals become financially devastated. Excess deaths accruing during the COVID-19 weeks may reflect both COVID-19 itself, but also deaths from healthcare disruption. COVID-19 overwhelmed a few dozen hospitals, while COVID-19 measures may jeopardize services and multiple health outcomes in thousands of hospitals. Moving forward, we need to defend hospitals and nursing homes with strict infection control and hygienic measures. We need to have universal and periodic testing of all personnel. We need to have quarantine for infected and exposed personnel. Conversely, we should reassure most citizens, those of younger ages, and of course, all of those without serious pre-existing conditions, but also many that just have hypertension or some mild condition, that they're at extremely low risk. Reopening efforts require great caution, with continuous feedback to identify and limit any potential surge of hospitalizations and deaths upon reopening. Reopening should be gradual, with continuous feedback on epidemic activity. This includes data on seroprevalence, which means the proportion of people already infected, and incidence of new infections. These data should be balanced against bed capacity reserves. It is unrealistic to expect that new PCR detected cases will disappear before reopening. PCR remains positive for a while in many patients who are no longer infectious. Moreover, with increased testing and with a large pool of previously undetected infections, numbers of PCR positive samples may seem to remain quite high, even though the epidemic wave has largely passed. It is also unrealistic to expect COVID-19 deaths to stop accruing before reopening. Deaths may happen 3 weeks after infection, and modern medical technology can maintain some people on mechanical support even for months. Finally, it is unrealistic to expect that complete contact tracing will need to be feasible before reopening. In most locations, the number of people infected is already too large, and their casual contacts may include a large portion, if not the large majority of the entire population, thus making complete contact tracing infeasible. Complete contact tracing can be more feasible when the epidemic activity has ceased, for example, in the future when trying to catch early and extinguish potential new waves. The pace of the reopening may differ across locations, depending on their evolving levels of infection, hospital capacity, and population vulnerability structure. While treatment advances and vaccine efforts may be successful eventually, lockdown measures cannot be prolonged until we find treatments and vaccines that save many lives, since such breakthroughs may take a long time or may even never happen. For example, remdesivir has shown promising results in shortening disease duration, but no conclusive evidence yet for saving lives. Thank you for listening.
Thank you, Dr. Ioannidis. Before we go back to Mr. Roy, we'll do have our last witness, Dr. Scott Atlas, testify. Dr. Atlas is the David and Joan Traytel Senior Fellow at the Hoover Institution at Stanford University and a member of the Hoover Institution's Working Group on Healthcare Policy. Prior to joining the Hoover Institution, Dr. Atlas was Professor and Chief of Neuroradiology at Stanford University Medical Center for 14 years. He received an MD from the University of Chicago School of Medicine. Dr. Atlas.
Okay, thank you. Thank you, Mr. Chairman, and thank you for inviting me to speak here today. As we all know, the consequences of the COVID-19 pandemic, of course, have been enormous. That said, the direct daily toll from the infection has markedly declined, including in the epicenter, New York. The curves have been flattened. The stated goal of the isolation has been accomplished for both hospitalizations per day and deaths per day, the two curves that needed to be flattened. We now, though, have an even greater urgency, specifically due to the extension of the severe single-minded policies already implemented. Treating COVID-19 at all costs is severely restricting other medical care and instilling fear in the public, creating a massive health disaster in addition to the severe economic harms that would generate a world poverty crisis with incalculable consequences. Half of neurosurgery patients still today refuse to come in for treatment of disease that, if left untreated, risk brain hemorrhage, paralysis, and death, even when their doctors directly reassure them because of the fear. Transplants from living donors are down 85% from last year. In the US alone, 150,000 new cancer cases arise every single month. These patients are not being seen. Biopsies of unknown, undiscovered possible cancers number thousands per week. They're not being done. That doesn't include the latest reports of skipping 2/3 to 3/4 of cancer screening tests, most childhood vaccinations, and treatments for emergency new strokes and known cancer chemotherapy. One more thing we absolutely know is that this total isolation policy prevents broad population immunity. We know from decades of neuroscience, of medical science, that the population develops immunity while acquiring antibodies. Indeed, that is the main purpose of widespread immunization, to assist with herd immunity. In the COVID epicenter of New York, undoubtedly muted by the extreme policies, we still see that more than 24% of those tested have antibodies, and a similar finding was reported in Boston. That fact has been incorrectly portrayed to the public as an urgent problem requiring mass isolation. But on the contrary, infected people are the immediately available vehicle for establishing widespread immunity among low-risk groups. While we do not know with certainty that antibodies stop infection, it is expected based upon decades of virology science, including with other coronavirus respiratory viruses. That's exactly why scientists are hopeful about using COVID-19 antibodies to treat the sickest patients. That's the basis for the drive to generate a vaccine. Reassuring the public about re-entry is critical, and it requires repeating the facts, what we know about the threat and who it targets. By now, as Dr. Ioannidis implied, multiple studies from all over the world suggest that the overall fatality rate is far lower than early estimates, and those were the estimates that motivated the extreme isolation. We also now know who to protect, because this disease, by the data, is not equally dangerous across the population. For example, in Detroit's Oakland County, 75% of deaths were those over 70, 91% over 60. Similar findings of New York. Again, healthier, younger people have virtually no risk of death and almost no risk of serious disease, and similarly, highly unlikely to be hospitalized. Here are specific science-based logical steps strategically and safely restore the pathway to normal life. First, we must finally focus on protecting the known most vulnerable. That specifically is nursing home patients. Given that older people with underlying conditions were always the obvious setups for serious complications from respiratory diseases like this, it is difficult to even excuse policies that allowed almost 30% of US deaths to die in nursing homes, more than half in some states, particularly when they already live in controlled access. This is an urgent need and probably too late to help for most people, but targeted strict regulation of all who enter, including mandatory testing for these people, must be done. We must continue to educate and inform the public about what they have already learned regarding at-risk age groups and how to deal with them. In addition to the standards of hygiene and appropriate social distancing that we already know, that has to be reinforced, and we know that people can do it. That's what's being done. Second, those with mild symptoms of the illness should strictly self-isolate for 2 weeks. It's absolutely not urgent to test them. We assume they have the infection at this point. That includes confinement at home, having the highest concerns for sanitization, wearing masks when others in their homes enter their room. Third, K through 12 schools should be opened. If under 18 and in good health, you have virtually no risk of serious illness. Exceptions exist, as they do with every single clinically encountered infection, but that does not outweigh and cannot outweigh the overwhelming evidence to the contrary. Again, standards for consciously protecting elderly and other at-risk family members and friends, including the teachers in high-risk groups, should still be employed. Fourth, most businesses can be opened, including restaurants and offices, but of course we require new standards for hygiene and sanitization with more stringent regulations than we've had. It is reasonable to post warnings for customers who are older or in other ways at risk. And indeed, we already see businesses and workplaces setting up such environments because they already understand the obvious need to allay fears of workers and customers in order to regain function. However, it is not logical that younger age groups must somehow be isolated or maintain a 6-foot spacing from each other. If infection in low-risk groups is still prevalent, which it is, socializing represents the opportunity for developing the widespread immunity, eradicating the threat to the vulnerable. Fifth, public transportation, which is the lifeblood of much of the workforce, should resume. In addition to the standards of cleanliness and hygiene that passengers would welcome, of course, regional authorities could require things like barrier masks for passengers. Given the state of our fearful public, it is highly likely that most people will choose to wear them. Similarly, air travel hygiene has already been improved, and further changes are likely regardless of any requirement because travelers will simply not have the confidence to fly. 6, parks and beaches should be open. There is no scientific reason to insist that people remain indoors. Given now that we know who to protect and how to protect them even inside our homes, outdoor activities can resume with smart considered limits on large group gatherings. Finally, prioritized testing is important, but it's important in 3 specific groups: nursing home workers, healthcare workers and first responders, and patients in hospitals with respiratory symptoms or fever. Widespread testing for the entire population is not a predicate for reopening as above with these guidelines. And contact tracing, although an important part of the overall preparation for potential future outbreaks, is not critical right now and is not as valuable after a disease is already widespread, infecting tens of millions of people. In summary, targeted protection for the known vulnerable, standards and common sense recommendations for individuals and businesses, and prioritized testing are the basis of an urgently needed strategic re-entry plan that would save lives, prevent overcrowding of hospitals, and limit what are the enormous harms compounded by continued total isolation. Smart, safe re-entry cannot be delayed by fear or hypothetical projections. We have direct data on risk, and we have now experience with managing it. The goal of the strict isolation has been accomplished. We need to stop underemphasizing the actual empirical data and establish medical science while instead somehow doubling down on hypothetical models. Science and logic must prevail over fear in worst-case scenarios. Thank you.
Thank you, Dr. Atlas. Mr. Roy, you're back. I think we heard most of your testimony. Do you want to finish off, though? Do you know where you blinked out?
I'm happy to finish up if it's helpful.
Okay, go ahead, Mr.
Thank
Roy.
you. So I was mentioning that something similar can work for COVID-19 in terms of the analogy I made to traffic fatalities and responsibility for the roads. Businesses can clean their surfaces and provide hand sanitizer and masks to their workers and customers. People can wash their hands regularly and minimize close contact with strangers. This is, in fact, what East Asian countries did during the original SARS outbreak in 2003, and it enabled them to gradually return to normal life despite the absence of a vaccine or effective treatments. We discussed this and many more opportunities for strategies for reopening in our coherent, bipartisan, evidence-based plan for reopening the economy called A New Strategy for Bringing People Back to Work During COVID-19, co-authored by Lanhee Chen of the Hoover Institution, Bob Kocher of Stanford University, and Bob Wachter, chair of the Department of Medicine at the University of California, San Francisco. The report is available at our website, freeop.org. I look forward to discussing these ideas during today's conversation. Thank you very much. And again, apologies for the interruption.
Not a problem. Thank you, Mr. Roy. Just out of respect for everybody's time, I'll hold off on my questioning till the very end. I will just warn everybody, not warn, but give you heads up in terms of witnesses. I think during my questioning, I will ask each of you to, if you have something you disagree with another panel member, I don't want to get heated arguments, but I do want this to be a discussion and challenge other people's assumptions or conclusions as well. So that'll kind of be what I'll go after at the very end. But otherwise, we'll go down in order of basic seniority. I will again remind the members, I will let you during your 7 minutes pretty well control the little hand thing. If you see one of the witnesses that you did not call on that puts up his hand and actually wants to speak to your question, I'll let you determine whether or not you want to call on that individual or just move on to your next question. So if you do, as a witness, get your little hand up there and doesn't get called on, don't want you to be offended. People may not be noticing it, or they may want to direct their question to another witness. With that, Senator Peters.
Great. Well, thank you. Thank you, Mr. Chairman, and thank you to all of our witnesses. Fascinating testimony and certainly really a range of ideas for us to be thinking about. My first question is to Dr. Inglesby. I've been speaking to a lot of our businesses all across Michigan over these last few weeks, and certainly everyone is anxious to try to find whatever that new normal is and try to open up their businesses. And a number of the very large businesses in Michigan have developed very detailed plans. Our auto industry, for example, has put together elaborate plans to keep their workers safe as they open up production in the future, to keep them safe, spacing folks out, making sure certain exits and egresses are used, and traffic flows, temperature testing, et cetera. All of these basic guidelines are being put in place, and some of the major auto suppliers will be able to do that as well. However, I'm concerned that many small businesses simply don't have the resources on their own to put together that kind of plan for their business, and will have to figure out how do they operate to keep their employees safe, and equally as important, make sure customers feel comfortable coming into those places that are open. So my question to you is, what more could the federal government do to help those small businesses really understand what they need to do in order to keep their employees and their customers safe? How should we be thinking about it?
So, Senator Peters, I have heard from big businesses and small businesses that what business really wants is some kind of very, very clear and detailed guidance from the federal government to help them set their own standards. They worry about their own employees not feeling confident in coming back to the workplace. They worry about customers not feeling confident that businesses have necessarily taken all the right steps. So for them, at least what I have heard, is that they really would like detailed guidance from CDC or OSHA that would help them measure themselves. They're not necessarily asking for new regulation, but they're asking for a lot of clarity about what a safe environment looks like in different kinds of work, both retail, construction, office space, a variety of different settings, really tailored to those industries. So for the industries you're talking about in Michigan, both in the automotive industries, but also in agriculture, the more detailed guidance that employers can get, that workers can see, I think the better. I think the other thing for places that are large indoor facilities, they definitely are going to need access to the right kind of protective equipment. We've seen, now we've seen countless meatpacking facilities get very large outbreaks. We've seen outbreaks in prisons. We've seen outbreaks in nursing homes, in cruise ships. Indoor congregate settings are really among the highest risk places. We do think, fortunately, that smaller businesses are probably at lower risk. There's less people coming in and out of those organizations. They're less dense. But certainly, I think many of them would like to get either from a state agency or even probably for many who work in multiple states, they would like some kind of federal clarity about what they should be doing.
Thank you, Dr. Igglesby. And I want to actually pick up on a point you mentioned about having personal protection equipment and how important that's going to be outside of just medical settings, where clearly that's where the priority is. But if we look at what has transpired over these last few weeks, it has been a real challenge to get the masks, the respirators, the gloves, just to our critical frontline folks, our doctors and nurses and med techs. But as we start looking at opening up the economy, the demand for PPE is going to go up dramatically. So my question to you is, do you believe that the current supply chain is prepared to meet these needs right now in your assessment? And I know Johns Hopkins has done some assessment of that.
Yeah, it's difficult to know because there aren't any clear metrics that I think are being put out by the federal government or state governments on this. I think if you speak to hospitals, it's a patchwork. Some hospitals feel like they've been able to get PPE that they need. Other hospitals clearly do not feel that way. And we haven't been able to really extend PPE supplies to industry in the way that industry seems to be seeking, and I think is quite important. My colleague at our center calculated that over a 100-day period in COVID, so a 3-month period, the country would need an additional 3.3 billion gloves, 57 million N95 masks above normal usage, and 179 million surgical masks for use around the country in healthcare facilities. This is exclusive of the need for business or for the need to use those masks in other settings. So I think that's a very high demand. I don't know whether we've met it. There's no real way to measure that. And that was for the first 3 months of this illness. So as this illness, as COVID goes on, we'll need to reassess, see where we are in the outbreak, see how it's responded to the coming changes in our social distancing policy, and then make decisions about that.
Well, those are big numbers. And when you multiply it by all of the businesses that are going to need it, they're astronomical numbers in terms of what we're going to need. And given our supply chain that we have now is primarily overseas, most of all this equipment is produced in China and other places. Give me your sense of how important it is for us to be thinking about bringing back production from China, or actually taking it back. A lot of it has gone over there, to take it back, and how we really need to source this type of manufacturing capability in the United States, not only to deal with this pandemic, but future pandemics.
Yeah, I completely agree with that. I think, unfortunately, for both for PPE, but also for antibiotics, a majority of what we get is from overseas. And that's been done for kind of commodity, getting the cheapest pricing over the years. But at this point, I think, given the experience we've lived through, it's been searing and terrible. I think we should be very dedicated in bringing back those kinds of industries that we will need in future emergencies. And that doesn't mean we need to bring back the production of every medicine in America, but bring back the medicines that we believe we will need in the first months of a crisis, the PPE that we will need in the first months of a crisis that we can't afford to have cut off from overseas productions. I think that should be a strategic goal of ours coming out of this pandemic.
Great, thank you. Thank you for those answers. Thank you, Mr. Chairman.
Well, thanks, Senator Peters. Again, I want to apologize to everybody for how we started late, and I realize some of you are going to have to go. We will not be offended if you have to go on to other things. So, perfectly understandable. What I will do is I'll alternate between parties now, based on seniority, who's actually in the WebEx seminar right now, so I don't see Portman, Paul, or Langford. So I think I'll go next to Senator Romney. I see you're on. If you're ready, Mitt.
Yeah, thank you. I am. Just a couple of comments first. I appreciate the work that each of these individuals has provided and their testimony today. A couple of comments first. Mr. Roy's comment that comparing, if you will, the number of deaths with 1918 as well as from the standard flu, I would note that, yeah, there are much lower numbers than one might associate with this pandemic. But the president just last night said that without the actions he had taken to close down the economy, we'd have had 2 million dead. So I think we have to recognize that while the numbers we're looking at are consistent with a normal influenza year, at least so far, we've taken pretty dramatic action, and that's perhaps one of the reasons why they are not as high as they could have been. Dr. Atler also indicated that the COVID infection rate has declined, that the curve is now aiming downward. I think that's true if you include the tri-state area, or frankly, just New York. But if you look at the national figures, excluding New York, why the numbers continue to go up. I think we have 19 states that are actually seeing the number of infections and the number of deaths going up. But my question that I'm going to pose to Dr. Ioannidis or anyone else who would like to comment on it is this, which is I feel as you do that, this is very much like a standard flu. Maybe we've overestimated the mortality rate associated with this, and it's very dangerous for people who are older or who have underlying conditions. And I look at the data that came from Massachusetts and from New York and from the prison study in the South as well, and it all suggests that there are a lot of asymptomatic people, and that perhaps this doesn't have the mortality rate that we feared. On the other hand, I look at the data that comes from the meat packing facilities, the number of people who died that just work in the meat processing area. Likewise, grocery store stocking clerks. I mean, a normal flu, you don't have, dozens of people died that are stocking clerks. You don't have dozens of people die that work in meat packing processes. What accounts for that phenomenon that you're seeing a lot more deaths than you would normally see? Were this just like a standard flu for people, under 50 years of age?
I think that the reason for that paradox, which is indeed very prominent, is that there's a very steep gradient of risk. Influenza has less steep of a gradient of risk across age, even though it also has an age gradient, and also a less steep gradient of risk across people who are at high risk in facilities like those that you mentioned, even more so in nursing homes or in hospitals that you may get hospitalized, people getting infected with nosocomial infections. In contrast to influenza, we do not have a vaccine. So staff in nursing homes, for example, typically have very high rates of vaccination. Same thing for personnel in hospitals, in acute care hospitals. So it is pretty different when it hits these locations where you have a lot of vulnerable individuals clustered together, and you don't have the same background of vaccine protection that we have for influenza. However, this being said, we have the means to protect these specific locations that can be the places where disaster can happen. And the vast majority of the population, their risk would be the same or even less compared to influenza. Influenza, for example, kills thousands of kids around the world every year. And this does not happen with COVID-19. It kills lots of very young, completely healthy people. This does not happen with COVID-19. We need to be smart. We need to avoid the disasters. We need to protect very carefully all the settings where we can get a disaster. And at the same time, mobilize something like 85, 90%, perhaps more of the population who would be at minimal risk or very, very low risk.
Yeah, I do understand that. Although people who are working in food processing and working in grocery stores are not a population that we would think we need special care for. I mean, I understand certainly nursing homes and the like. Yes, we really need to make a very special effort there. But these are normal Americans that are seeing a very high level of mortality, which is inconsistent with the idea that this is just the sort of the normal flu type mortality. Another question that I had for you Dr. Ioannidis, is this, which is I really wonder how many people are asymptomatic. There's some studies, the prison study in the South, for instance, in 5 states in the South, I think it was, suggested that like 93% of the people that tested positive for COVID-19 had no symptoms. And if that were the case, you'd say, well, there's no way to stop this from spreading rampantly through a society. You couldn't possibly get people who are asymptomatic to know that they need to isolate. But on the other hand, you got a place like South Korea, which has pretty well snuffed out the extent of the disease. And there are other places, Australia, New Zealand, and so forth. So if there were massive numbers of asymptomatic people, how would they have been able to snuff out the number of severe cases that we're seeing in the rest of the world? It's hard for me to square some of the data. That's the challenge I have. I look at some data that says all sorts of asymptomatic people, then I look at the others and I say, that's impossible. Where do you come down on that? What do you think the proportion of our population is that's really asymptomatic and is still spreading the disease?
I think that all the studies point to the fact that asymptomatic infections or mildly symptomatic infections that do not reach the level of attention that people would want to be tested are the vast majority. If you retrospectively ask people, of course, if you ask them, did you have any cough or any symptoms in the last few months, probably most of us will say that, oh, yes, I can remember something maybe, who knows, 2 weeks ago or 4 weeks ago or 2 months ago. But the vast majority of infections are not at a level that would draw attention, either asymptomatic or very mildly symptomatic. What happened in South Korea and also in Taiwan is that they were very aggressive in testing very early on and in tracing contacts of people who were infected. Taiwan is a country that has practically one large international airport. They were very aggressive to just test everyone who could be suspicious and then quarantine and then test all the contacts and again quarantine. And this worked. It worked very nicely. And if we have a new wave or let's say a new pandemic, this is the way to go, especially if you get it very early on, to have that intense testing and tracking. It's not going to work in a situation where you have 30% of New York already infected at the moment, or 5% in other states, or 10%, or 12, or who knows. It's very, very difficult to contract trace when you have a sizable portion of the population already infected. They have been exposing almost everyone else to the infection. South Korea had more cases, but actually they had a very big outbreak in a religious sect. So they knew how to limit and how to contain the boundaries of their testing. And they also were very aggressive in asking people to come in and get tested right away.
Thank you.
Thanks, Senator Romney. Again, I want to just draw everybody's attention to the 7-minute limit. I'm mindful that 3 of the witnesses put up their hand, but that's up to the senators to call on those individual witnesses if they choose to. Our next senator up to the plate is Senator Carper.
I used to have the privilege of chairing this committee, and now the Senior Democrat on the Environment and Public Works Committee, which reported out unanimously today major legislation on water infrastructure. Sometimes people think we can't find anything to agree on, but every now and then we do. What do they say about a blind squirrel occasionally finds an acorn? Well, we're going to look for some acorns right here with all of you. I'm going to ask Dr. Inglesby, if you will. Dr. Inglesby, I'm going to ask you to just go back and think about what each of our other witnesses have said. We'll start with Dr. Atlas. Just pick something that Dr. Atlas said that you agree with. You thought it doesn't have to be profound, but do you think that it's if we're actually doing a real hearing, what I would do would be to ask, go down the line and ask each of you to see what are all the points where you agree. I don't know that works today, so I'll just pick on you, Dr.
Sure.
For something that Scott Atlas from Stanford, our son went to graduate school. Nice to see you. But something he said that you think, yes.
I agree with Dr. Atlas about the critical importance of doing better with nursing homes and how it has been, I'd say, so far, a collective failure across the country to be able to prevent so much sickness and death in nursing homes. I think that's very important.
All right, thank you. How about I'm going back to Dr. Katz. Dr. Katz, can you recall something that Dr. Katz might have said that you said, well, that makes a lot of sense. I agree with that.
Yeah, let's see. I think Dr. Katz is right that many people are deferring hospital care, and that's creating its own secondary large problem. And we need to communicate better with people that they should be coming to the hospital and getting their regular medical care.
Thank you. And Dr. Ioannidis. Dr. Ioannidis, has anyone ever mispronounced your name?
I think that there's 80 variants and all of them are equally fine.
All right. Dr. Inglesby, how about something that Dr. Ioannidis said?
I think Dr. Ioannidis said something along the lines of how important it will be to measure very carefully as we begin the next phase, and to be very carefully monitoring how our social distancing changes are affecting the disease rate. I think he said that.
All right. And how about something that Dr. Roy might have said? Dr. Roy. It's nice to see the faces of all these people, as you mentioned.
Yeah, and I'm trying to remember as we go. I think Dr. Roy,
say, I never said that.
Dr. Roy talked about the profound economic hardship that this disease is causing across the country, and I absolutely agree with all that he said about the hardship that Americans are going through, the job loss, the importance of considering strategies now that we can to reverse that.
Right. And Dr. Kory, Dr. Kory didn't have much time to talk today, but do you think anything that he said in his remarks?
I'm sorry. I think I
conflated. You conflated.
I think I mixed up two of the speakers. Well, I think the speaker who was speaking, Dr. Roy was speaking about, I think Dr. Kory was speaking about medical interventions, and I thought his discussion about how the conditions in New York City and the urgency with which we needed to deal with the onslaught of, or the incoming numbers of patients who need critical care. I thought that was very important.
All right. And now back to Dr. Roy. Dr. Roy,
I think that was what I said before about the economic losses and the hardships. I agree completely with his assessment of the economic implications of what's happening.
If you, we don't have many doctors who have served here in the United States Senate. We just lost a former a ranking member of our committee, Tom Coburn, died last month, very sadly. He was a great member. But if you were serving on this committee, let me just go through the list again. I'll just start with Dr. Roy. If you're serving here with us in the United States Senate, what would be one thing that you would focus on and getting us out of this and back on the right track? It's very, very, very briefly. Dr. Roy, please.
A great question, Senator. In the plan, I'd say that the things that we would highlight are, particularly for what Congress can do, is give safe harbor to businesses that can reopen. But one thing I would just amplify what's been said before about guidance from OSHA and CDC. It's also important to give liability protection to businesses that reopen, but also give aid to workers who don't feel confident to go back to work, some sort of paid sick leave or some analogy to that, so that businesses can get back to work, and workers can feel confident and have relief if they don't. Similarly, aid to schools.
Hold it right there. I see Senator Harris has joined us. I think she's asked me if I would yield my last minute. So I have 30. I have 92 seconds. Do you have time? Will she be recognized, Mr. Chairman? Or otherwise, I'll yield what's left of my time.
No, that's fine. If you want to give her 90 seconds, go ahead, Senator Harris.
Can you hear and see me?
We can hear you.
We can hear you now. Yep. Go ahead.
Okay, and hopefully you can also see me. Can you see me?
No.
Okay.
Yes.
We got all of you.
Okay, great. Thank you, Senator Carper. It's very brief and very to the point. Chairman, we have, it has been 2 months since our committee last met to remotely discuss COVID-19. And at the time that we last met, the number of coronavirus cases were about 200, and now they're 1.2 million. The death count in the country has gone from low double digits to over 70,000. And of course, these are our neighbors and our friends and family members. And then let's not talk about the global crisis around the world. It's now affecting 186 countries. I said at our roundtable in February, and I'll repeat it, that we must hear from the officials who are currently responsible in the administration, who are currently responsible for addressing this pandemic. Our Congress has passed 4 consecutive relief bills totaling at least $3 trillion. And there have been a multitude of problems with the way that that money has been dispersed, be it PPEs to frontline workers, be it small businesses and minority-owned businesses who are not getting the relief of the Paycheck Protection Program, be it the fact that we do not have enough testing to reasonably reopen our country. And so it is our job as our committee, given that FEMA is responsible for organizing and coordinating all of the federal agencies, and of course, our committee has the responsibility for oversight of FEMA, that we bring current administration officials in to discuss with us what their plan is for the administration of taxpayer dollars. And at the Help Committee, they're having Dr. Fauci come. They're having the point person at the top level of the administration. We should do no less. We should not have low-level officials. We should have those folks who have the responsibility and the authority for the administration of the American taxpayer dollars to come in and be accountable to our committee in our responsibility of oversight. So that is my request of you, which is that immediately we bring those top administration officials in to be accountable to the American people, to get the American people through this pandemic and through this crisis in the most efficient and productive way possible.
Well, thanks, Senator Harris. We will absolutely be doing oversight. I've certainly been participating in multiple hour-long conference calls with officials across the administration. I know Senator Hassan has been on a lot of those calls. I think those things are pretty wide open to members. So they have, the administration certainly has been briefing us. We will do the oversight. Right now, those folks are working like 24/7. So I want them concentrating the job before they start testifying before Congress. They're briefing us quite regularly. But what we'll do now is we'll move on to.
That logic would suggest that we don't have them come in before there is a vaccine, which of course is unacceptable. We have a responsibility to engage in oversight, Mr. Chairman, and I've registered my request of you and what I believe to be the mission and the responsibility of our committee. I appreciate your giving me this time. Thank you.
Okay, I understand. Senator Hassan. No, actually, Senator Langford is now online. So, Senator Langford.
Jumped in between you there. Good to get a chance to be able to hear all the testimony. I appreciate all the folks that are here. Let me bounce a couple of questions. Dr. Kory, I want to go back to some of the statements you made at the very beginning. Thanks for your description of what you've already done and the process you've gone through and the different ways that the disease itself is presenting. And it has changed pretty dramatically from just shortness of breath and everyone talking about this being a lung issue to now being blood and heart and all the different aspects that are coming up now. You made a comment about intubation of patients. I want to be able to follow up on that a little bit. Are you suggesting that we're using too many ventilators, that we're using the wrong process, that we're using intubation too often? What has changed in what you have seen in the process of taking care of patients?
Terrific. That's a terrific question. Okay, so let me tell you what I've understood. And again, I don't want to claim to be the world expert, but I will tell you I've been talking every day for 6 weeks to people all around the world and mostly in New York. Here's the issue, is that when this disease first presented, all the doctors were quite intimidated because there were so many reports of like this acute respiratory failure where patients could not breathe on their own. And so a lot of systems and a lot of institutions, they decided to adopt these early intubation protocols. Whereas traditionally, when we see someone who's having difficulty breathing or in respiratory distress, it's a challenge. I'm a pulmonologist and a critical care doctor. I have never in my career been able to decide when to intubate someone. It's a chronic challenge because you don't want to intubate too early and you don't want to intubate too late. Because if you intubate too late, sometimes it leads to cardiac arrest and it leads to very poor outcomes of the patients. If you intubate too early, you might put someone on a mechanical ventilator in which the harms of mechanical ventilation will be profound. whereas you could have avoided that if you didn't intubate. And so that, I just want to say that's the core challenge of my specialty. When COVID came along, it was just, it's weird, the reports coming out of China and Italy about how non-invasive ventilation and other respiratory support structures were failing. Many people in this country, around the world, around the country, said, you know what, the best thing is to intubate them early. They're going to fail. Let's intubate them early and protect them. And that's what happened a month and a half ago. I fought against that. I thought it was going to be harmful to intubate patients too early, although the severity and the acuity of this disease and how rapidly it progresses, we really didn't know. But I was on the phone every day talking to patients, talking to my colleagues around the country, asking them what they were seeing. And so all I'm going to do is, I'm going to finish with this, is that most centers around the country, I believe, adopted early intubation protocols in which they put patients on ventilators probably, and they thought safely before they needed to, but that led to untold harms. Now, what I'm seeing in New York City is unbelievable. I am seeing in my hospital here that I'm working at, is we have a tolerance to avoid intubation to the extremes. These patients are being supported with oxygen support, non-invasive ventilation, and we're avoiding intubation because the outcomes after you put them on an invasive mechanical ventilator are really, really dismal. And so we're trying to avoid that at all costs. And so it's really a moving target, and we're evolving in how we approach this. But it's a challenge. I don't know that we're getting it right. But all I can tell you is I think we got it wrong in the beginning, but we're doing much better now.
Yeah, that's extremely helpful. I really do appreciate the insight on that, because you've got a chance to be able to see, obviously, a lot of patients and a path that you're seeing for care. And I'm grateful for folks that are early on trying to be able to work through to be able to solve this, because you're going to be able to share a lot of wisdom and insight to a lot of other folks. Let me shift to something that Dr. Katz had mentioned before. Dr. Katz, you had mentioned something about a unique moment to deal with the health of Americans. You could drill down on that. Obviously, there's a lot of conversation about diabetes and being overweight and dealing with greater heart strength through exercise and such. Is that what you're talking about as a part of being preventative on this disease? Or are you suggesting that what you're seeing in COVID-19, you're less likely to be able to face the severity of the symptoms from COVID-19 if you're doing exercise, if you're taking vitamins, if you're eating healthier, if you get your weight down? Is that what you're suggesting?
All of the above, Senator, and thank you. And actually, I think this relates back to a question Senator Romney raised a little bit ago. Why were we seeing higher rates of severe disease among people working in a meatpacking plant?
Right.
There really is a perfect storm of confluence where the portion of the population most harmed by unemployment because they were living hand to mouth and struggling most perhaps to access the medical system, and most burdened with those chronic diseases that sadly are all hyperendemic in the United States: obesity, type 2 diabetes, heart disease, all occur in the same population. And so I think among the strategies we have to adopt, and there really is an opportunity here at the federal level to provide leadership, I think we've been relatively, if I may say it, contemptuous of chronic disease simply because it's chronic. The human nervous system is sort of hardwired to perceive threats that come at us fast. The fight or flight response, right? It's something that's coming at you in seconds, minutes, hours, maybe days, activates your adrenal gland, gets your attention. Well, COVID has it. Everybody's fixated on this. But a large segment, I actually shared via the chat function of paper that colleagues and I just pre-published today, looking at the prevalence in the United States of these chronic disease liabilities that increase the acute risk for severe COVID infection. So that's exactly what I'm saying. These things are hyperendemic, but the good news is dietary practices can modify immune function, improve immune balance in a matter of hours, significantly in a matter of just days, and profoundly in weeks. Control of type 2 diabetes can be improved significantly with lifestyle intervention over a very short period of time. Blood pressure can be lowered. Inflammatory states can be mitigated. So the very same things we maybe should have been thinking about before to make America healthier now really becomes a matter of acute defense against COVID. I think we can also use, in addition to representative random sampling to get a good understanding of the national data, we actually can use risk calculators to determine what is the risk of severe infection, hospitalization, ICU need, or even death at the individual level, and then offer up resources to individuals by various means, some via the internet, but all the resources at our collective disposal to empower people while they're sheltering in place as we transition to the next phase of policy, actually acutely lower their risk. A sizable portion of our population could shift from the higher risk group because of their current state with regard to chronic disease and weight and inflammation, and migrate down to a lower risk group by using lifestyle as medicine. I don't think there's ever been a better opportunity. And frankly, we think about the health of the population both acutely and chronically. This is clearly a homeland security issue. So this is a great place to take up that mantle.
Thank you. Mr. Chairman, thank you for the time, and thanks for pulling the hearing together.
Thanks, Senator Langford. Senator Hassan.
Very much. Thank you very much, Mr. Chairman and Ranking Member Peters, for having this hearing. And it is good to hear agreement about the importance of population health to our homeland security, because that's one of the reasons that so many of us want to make sure that every American has access to good health care all up and down the spectrum. I also wanted to thank all of the witnesses for your participation today, and just comment on the fact that what I'd like to focus on is not a binary choice between opening our economy and having more people get COVID-19, some of whom will terribly and tragically die from it, or stay in a lockdown forever. I think there is another path, and it is the path that public health experts have been talking to us about, which is how do we implement public health tools, use the right kind of public health tools to reopen safely, protecting life as well as livelihood. So, Dr. Inglesby, I'd like to start with a question to you, please. First of all, thank you for your work during this pandemic to help provide medical and scientific expertise about what we need to be doing to keep Americans safe and our country strong. There's already been some mention in our discussion today and in some of the testimony about the need for more daily testing, but I want to return to that topic because I think it has to be a focal point of any conversation about reopening the economy. As you know, there are a variety of reports from public health experts projecting how many tests per day will be required nationwide as a part of a safe reopening strategy. The Center for Ethics at Harvard recently put out a blue ribbon report stating that as a nation, we may need 5 to 20 million tests per day. Other estimates have been even higher. So, Dr. Inglesby, while I realize that modeling can vary and is dependent on a variety of factors, based on your research, have you determined how many tests we need to perform on a daily basis in order to fully reopen the economy nationwide? And are we at that level currently?
So right now we're testing somewhere in the order of about 250,000 people a day, give or take. And we have been focusing primarily on people who have severe illness, people who are hospitalized, people who are in nursing homes. And then to some extent, the outbreaks that we've talked about, meatpacking, et cetera. We know that we're missing a large number of people with that strategy because we haven't had testing to be able to reach out to them. So people who have mild and moderate illness that could be COVID, we're not easily able to test them. They either can't get a test or they can't get it quickly. And so our estimate in our center is that given the number of people that we believe have been infected in the country that have not been counted, we believe we need to scale up testing by an order of 5 times or so daily. So that would be about 1 million tests a day to get the full complement of everyone who has COVID symptoms on a daily basis in the country. That might go down if the epidemic gets better, but for now, given the numbers that we have, we think that would be the approximate number. What that doesn't, I was just going to say, it doesn't include, the one thing it doesn't include, which the Harvard Center also tried to get to and others, is the second category of organizations that want testing, which is business in America and institutions, universities. They want to include testing as part of their reopening strategy. They want to incorporate screening. They want to incorporate sentinel testing. And so if you include that, that's another additional set of testing, which we have, there's no real estimate yet that's been been created by big business in America, but I think that would add millions of tests a day if we actually are able to do that.
And do you have an idea of when we could reasonably expect to get to the point where we are doing the level of daily testing that you're talking about? Let's start with the million that would be testing people with symptoms or on the front lines and the most ill. And what will it take to get there?
I talked to a representative from the diagnostic industry earlier this week, and their sense is that they are getting close to that number in terms of being able to manufacture that number of tests, 1 million tests a day. But clearly that number is not actually happening. And part of the reason for that is maldistribution in the country. Part of that is lack of reagents. They might have a test kit, but they don't have the right reagent. Right. They may not have swabs. So to get the whole, we may have actual kits for that many people presently, but we don't have the full package or the operational planning to be able to deliver those tests to where they need to get.
And what could we do as Congress to help us get there?
I think continued monitoring of industry and a commitment to the industry that this market is secure, that if they make tests for COVID-19, they will be purchased by the US government for this process. And I think that's probably something that they're aware of, but I don't think they have a sense of what market size the US government wants or US industry wants. And so there's some uncertainty. Should they make capital investments? Should they shut down other lines in favor of this one? Are they going to be crowded out by other diagnostic developers? I think it's a complicated calculus for them. And the more that the US Congress and the administration could say, we intend to purchase these, we intend this market to be secure, it will grow over time because we need it for business, university, institutional purposes, as well as public health, I think that could help.
Okay, thank you. I have one other question for you, Doctor, and it follows up really on the line of questioning that Senator Peters had. In recent weeks, even with social distancing measures in place, we've seen outbreaks of the disease at businesses and at gatherings across the country. For example, 81 employees tested positive at a Walmart in Massachusetts last week. It's unknown how long the virus was spreading within that store or how many people those employees had contacts with. In order to reopen in a way that keeps employees, customers, and families safe, we need to be able to contain these types of outbreaks before they become widespread. And that requires support beyond diagnostic testing for people with symptoms. So we talked with Senator Peters some about the things businesses can do to open safely, the kind of guidelines they need. But could you focus a little bit on the importance of robust contact tracing to contain community spread and immunity or vaccine registries that could be used to protect high-risk individuals?
So all countries in the world that have done well against COVID-19 so far have had very strong public health capacity and the ability to do contact tracing and to isolate cases and then quarantine contacts and track them over 2 weeks. We saw that in places around Asia. We've seen it in New Zealand, Iceland, countries in Europe. The places that are succeeding have very strong contact tracing programs. And we are beginning to move in that direction. States have announced programs to hire many contact tracers. Congress has done a number of things moving in that direction. The reason why that's so important is because that's a way to cut off the chains of transmission. That's a way to get people isolated so they're no longer infecting others, and that gets people out of commission for a bit at home, and it begins to drive down the numbers of infections. And we've seen this in great detail in places around the world. So we need to build that. It's not complicated to do it, but it takes some time. It takes resources for states to hire people. It doesn't need to be a commitment for 10 years, but it needs to be a commitment for the course of this pandemic.
Well, thank you. I think it also would be very important in terms of giving the public confidence that when they do go out and they do engage in commerce or any other activity of their daily lives, that the likelihood of them being in a safe place is much greater. And I think that goes to the concerns that the public understandably has about this disease. Thank you, Doctor, for your work and testimony. Thank you, Mr. Chair, for this hearing.
Well, thanks, Senator Hassan. We don't have a Republican teed up. What I'd like to do is I see three witnesses with their hands kind of up. They want to say something. So I'll give them each a shot. I'd appreciate succinctness before we go to Senator Rosen. We'll start with Dr. Atlas, then we'll go to Mr. Roy, and then to Dr. Katz. Dr. Atlas.
Okay. Yeah, great. Thank you for allowing that. Just a couple of points of clarification. And these are things that keep being repeated, but they're just misconceptions. Senator Romney said that the curves are not coming down because the number of cases are actually going up in certain states. That's really not a curve to really watch at this point. We know that the more testing we do, the more cases we have. That's not a relevant curve. That was never a directive goal of the policy. The only curves that count are the number of hospitalizations per day and the number of deaths per day, not the number of cases. Second point that is, again, needs to really be clarified. There's somehow a false narrative that's being perpetrated that the people who don't want total lockdown are saying there should be wide open economic and isolation. That's actually not true. No one here is saying that. I don't know anyone who believes that. Everything is about targeted protecting the at-risk people and allowing people to get out who are not in those groups, particularly so that we can increase herd immunity. And then one more point, if I can, about testing. You know, the role of testing is important, but it's very different at various time points in a pandemic. The role of testing in the beginning for South Korea and the urgent needs were very different than it is right now, especially for contact tracing. We have tens of millions of people who have had the infection here. Contact tracing, it seems sort of absurd to me unless it's for preparation of the next pandemic. And then the final point, we keep discarding the massive harms we're killing people with total isolation and lockdown. I don't know how many times this has to be said, but hundreds of thousands of people have serious diseases that are not being treated. And not just that, the economics alone is causing a massive catastrophe that is in terms of health and poverty throughout the world, because many economies are linked, in fact, the whole world, to those of the United States and the Western world. Thank you.
Thank you, Dr. Atlas. By the way, is it Mr. Roy or Doctor? I don't want to.
Mr. Roy is fine.
Okay.
Is fine. Thank you very much, Senator.
How about Ovik?
Yeah,
Mr. Roy, go ahead.
Yeah. Similarly, I want to clarify a couple things. First, quickly, Senator Romney, I think, misunderstood my comments of comparing to other types of fatalities. I wasn't comparing to the flu. COVID-19 is clearly more serious than the flu, especially for people over 65 and those with cardiovascular chronic disease. My point was to analogize to traffic fatalities and hospital-acquired infections to say we don't shut down hospitals because 100,000 people die of hospital-acquired infections. We try to manage and mitigate and reduce those deaths. Similarly, with traffic fatalities, we have a whole regulatory system in place and impress upon people that need to be responsible. Those kinds of tools can be relevant here, just as they were in the East Asian countries that recovered from SARS in 2003. I want to make one other comment about the testing discussion we were just having. It's very important. I think a lot of people are under a false impression about just if we have X number of tests, then everything's going to be fine. We have to remember that antibody-based testing or serology testing does not generally measure an active infection. Antibodies only generate in a patient 3 weeks or 4 weeks after they've been infected. So for testing the population to see if they've been infected or they have a current infection, it's not going to work. And the DNA or viral RNA-based testing, RT-PCR tests, those are much more invasive at the moment, much more cumbersome, and very difficult to scale up. So when we talk about the number of testing, I think it's unrealistic to expect massive population-wide testing. And people who are interested in more details about that, we can either get into it in this hearing or you can review the freeop.org paper I mentioned earlier, where we delve into this topic at length.
Thank you, Mr. Roy. Dr. Katz.
Thank you, Senator. I also wanted to comment on testing, which I've seen up close and personal in the emergency department, and it is cumbersome. And one of the issues we have to overcome is the unreliability of a lot of the tests we're using. There still is a high false negative rate. But it does seem to me we're setting up a catch-22 if any semblance of return to normalcy is predicated on a number of tests we know we can't do and won't be able to do for the foreseeable future. I think we need to ask ourselves, what do we need the data for? We want to know what % of the population is likely to get this infection. Is it everybody who's exposed, or is it 1 in 5? So far, it really looks to be about 1 in 5 on Navy ships, on cruise ships, and contained populations. Of the group that gets this, how many develop symptoms? Of those, how many need to be hospitalized? Of those, how many are likely to need the ICU? Of those, how many are at risk of dying? And on the basis of what antecedent risk factors? How does that shift with the presence or absence of hypertension, coronary disease, type 2 diabetes, body mass index, and other factors. When we think about the utility of data, we really aren't bogged down with testing millions of people. We need a representative random sample large enough to give us that actionable information. That's much more doable. We have the resources to do it now. It's proximal, it's the work of several days. And if the goal of getting data is not just to say, look how much data we have, but look what we now understand to inform policy, representative random sampling will do. The other thing I wanted to say is that there's an alternative to contact tracing. And that is to say, we identify people at higher risk and we carefully protect them from exposure to the virus. And people at low risk, we actually expect the virus to circulate. So contact tracing in that group almost defeats the purpose of saying low risk people, if we're ever going to get our lives back and not be on the indefinite timeline of maybe there will be a highly effective vaccine mass produced, we actually need the virus to circulate among people who can safely get it, get over it, make antibodies, which historically, before the advent of highly effective vaccines, was how pandemics ended, immunity developed. But what we can do now, artfully, is say there are people who cannot safely get through this infection, we'll protect them. There are people who can, they can go back to the world. I think contact tracing at scale in that group is not likely to be helpful. And I think we should do better than contact tracing for the high risk, people over 70, people over 80, people with a large burden of chronic disease. We need to double down on protecting them so they're not exposed until we can document with ongoing, at least random sampling, that viral transmission is near zero, that a high level of protective immunity has been achieved, and then basically everybody's grandparents can hug their grandchildren safely again.
Okay, well, thank you, Dr. Katz. I feel bad because I lost Senator Rosen. I know Senator Sinema is available. So, Senator Sinema, why don't you go? And then I see Dr. Inglesby as well as Dr. Kory have some points to make, but let's go to Senator Sinema first.
Thank you so much, Senator Johnson. Can you all, and Chairman, can you all hear me fine?
We can.
Great. So thank you, Chairman Johnson, and to Ranking Member Peters for holding today's roundtable and for everyone's flexibility during this time of coronavirus. You know, we've made some hard-fought progress in my home state of Arizona in flattening the curve by adhering to social distancing and other guidance from the CDC. It hasn't been easy, of course, and everyone's made sacrifices. I don't want those actions to be in vain by reopening too quickly and triggering a second surge of cases that will further harm our hospitals and our economy. As you all may know, Arizona ranks dead last in the nation in terms of coronavirus tests administered per capita. This is from the latest data from the Kaiser Family Foundation that ranked all 50 states and Washington, D.C. They found Arizona was 51st in the nation. So the data clearly shows that Arizona has work to do before it's safe to get back to normal, and public messages need to reflect that. Ensuring Arizonans have the information they need to stay safe is my highest priority, but too many Americans are still confused about what's best practices to keep themselves and their families safe. We've already lost too many lives, and I have serious concerns based on consistent data and analysis from the CDC's infectious disease experts that opening too quickly or softening social distancing without a better understanding of the prevalence of the virus will lead to spikes in infections and deaths. We want the economy to open as quickly and safely as possible. But in my regular calls with mayors, county officials, healthcare providers, and small business owners, I hear directly from Arizonans who want to reopen and get back to normal, but they want to do it safe and they want to do it smart. Moving too quickly or taking on too much risk could lead to a resurgence of the virus, a greater loss of life, and longer lasting economic harm. So I've heard from business leaders that continually reopening and closing the economy could be an economic disaster for them. So we have a long way to go to get through this crisis. And I know that if we're safe and smart, we can bounce back from this. So I hope that this committee will also consider a future hearing when it's safe to do so with relevant members of the White House Coronavirus Task Force to provide oversight over our federal response as well. So with that, I've got a couple of questions for Dr. Inglesby. The administration has included contact tracing as one of the critical components involved in safely and slowly reopening localities following the guidance of infectious disease experts. How can states determine if their contact tracing model is robust enough to move forward with what's commonly known as phase 2, when a community is shifting away from slowing the spread and into opening and public places reopening?
So one measure is just the measure of contact tracers per population. And I think in general, at this point, it seems like with the early states, the numbers of contact tracers per 10,000 people is somewhere in the order of 1, 2, or 3 contact tracers per 10,000 people. That seems to be a growing consensus around that. We don't have evidence around that, but it seems consistent with other efforts in other parts of the world which have been successful around contact tracing. And the second thing is for a state to be able to say, can our state actually trace, can we isolate the people that are getting sick on a given day, and can we trace those contacts? In many states in the country, there are numbers that are low enough for starting today, if a contact tracing effort began, they would be able to isolate those cases and trace their contacts and put them in quarantine. So while we have to acknowledge that stuff that's gone before, those people are out there in the community, but starting now, we could begin to trace and isolate those contacts. But there are some states in the country where the numbers are so high and the number of contact tracers is so low that there'd be no chance of trying to be able to identify and trace contacts and get them in quarantine. So partly it's a function of the size of the state and the number of cases that they have. If they've got many cases on a given day, then they're going to have more challenges. If they have few cases, then their contact tracing force on hand may be able to cope with that as they hire others.
So a follow-up question on contact tracing. As you know, in Arizona, the hardest hit community we have is the Navajo Nation, where technology and access to technology and broadband can be very difficult to rely on. So, apps or phone calls may not work effectively in those communities. What should contact tracers do, and how can they do it effectively to help reduce the spread and hopefully contain before a second wave comes for the Navajo Nation?
Yeah, I think that's particularly important because my understanding is that in the town of Gallup, outside Navajo Nation, that it's a new hotspot. It shows that hotspots can arise in places that are kind of a traditional major urban centers, and it sounds like a really serious situation. I've also heard that Navajo Nation is having a lot of difficulty getting diagnostic tests and has really appealed to the administration to get more testing. So I hope that can happen soon. I think for places without access to high technology, human capital really is the most important thing in contact tracing. People who can call people up, understand who their contacts were, call them back the next day, make sure things are going well, make sure they haven't developed symptoms, make sure they understand what is going on. So even before we had any technology, contact tracing has been part of public health for a long time. It hasn't been needed on this scale ever in this country. But I think if we get the right people in place and do kind of relatively just-in-time training for those people, that can make an enormous difference. And then it could be supplemented by technology.
Oh, I appreciate that. A follow-up question for you. You're trained as an infectious disease physician, and you're still seeing patients at a clinic. So my question for you is, how does your training and your practice impact how you approach the testing, modeling, and development of strategies for reopening? Again, I'm concerned because Arizona is 51st in the nation in terms of testing per capita. How do you see your approach as different from that of an economist or other medical professionals?
Well, it's hard for me to speak about the perspectives of others, but I'll tell you from our perspective in our center and what I do, there has been a lot of development of diagnostic strategy within the hospital system. Hospitals very much need to know and want to know the status of a person that's coming in the front door. They want to know the status of all the people that are being treated as outpatients. We need to know if someone in our clinic has a fever. It's not enough for us to know right now that they have a fever. We need to know whether they have COVID. We need to know what the threshold is for them coming into the hospital. People with COVID can deteriorate quickly. So we need to know how they are doing at home. We check in with them over time. So our hospital system has developed a very kind of a sophisticated, layered way of making sure that its patients, when they get sick, are able to get tested. And that's really important for everyone who has COVID symptoms.
Thank you. Thank you, Mr. Chairman.
Thanks, Senator Cinnamon. Well, I'm looking at our participant sheet here, and it looks like it's just me and our witnesses. I want to thank, first of all the witnesses for hanging in there. I really appreciate it. This is, I'm sure, longer than we all thought this was going to go. I literally have 3 questions. One's going to be directed to Dr. Kory. 2, I'm going to ask all of you to get rid of your little hand signals there, because I'm going to ask you to put up your hand if you think you can really excellently answered the two questions. And then I'm going to give all of you, in reverse order of original testimony, a chance to either refute something or just whatever's on your mind, okay, in terms of the last thing you want to say. But let me start with Dr. Kory. I've been advocating quite some time publicly to really allow doctors to be doctors, to allow them to practice medicine, to explore different theories of the case, different therapies. It's certainly what you're doing once patients have been hospitalized. Certainly, I've been trying to find, whether it's hydroxychloroquine, I know so your testimony, you're talking about the potential benefits of that once we have the studies on it. But that looks like it's only effective maybe in the first 5 days of symptoms, probably even before a test comes back. You're talking about a therapy that once people are ill to present themselves to a hospital, that's the problem. Can you just kind of speak to the different stages of this disease, the different types of techniques? What will work early, what won't work very late? Just quickly address that.
Absolutely. I'm really glad you brought this point. I've listened to the whole discussion. I understand there's multifaceted parts of this disease and this epidemic. And I appreciate my colleagues. I am not in my lane when we're talking about testing and opening the economy and social distancing. That's not what I do. I know how to treat severe illness. Let's talk about that. So what we understand about this disease, and this is what we experts, is that there's two phases. One is the viral replicative phase, which is really in the outpatient. Those are those first symptoms of sore throat when the virus invades the soft tissues of the head and neck, where you get maybe some fevers, you don't feel well, and most of those patients actually do okay. If somehow this virus triggers this hyperinflammatory response where you go into organ failure or multi-organ failure, that's when you come to the hospital. And that's where I'm an expert. And so what we know about antiviral therapies and vaccines is that they are most effective early on in the disease. So things like hydroxychloroquine, which is purportedly an antiviral medication, should be given in the outpatient setting in the early days of symptoms. It's not a hospital drug. I've seen too many patients dying on hydroxychloroquine in the hospital. The idea that you should wait until they come and they fall so ill in the hospital, to me, as a physician, doesn't make any sense. Remdesivir is the same thing. Why would you give it to patients already in the hospital who are in severe stages of disease? We have to understand this as two stages. And so the early part, when you talk about vaccines, hydroxychloroquine, or remdesivir, that should be focused in the outpatient setting. Come to me. I'm a hospital doctor. Once you come to me, it's the hyperinflammatory phase. We're talking about cytokine storm, multi-organ dysfunction. And that's why I tried to talk about the fact that we really need powerful anti-inflammatory and anticoagulant drugs. And if we employ them early and systematically, I really believe we're going to change the trajectory of the massive morbidity and mortality that we're seeing. I understand all the public health experts, and I understand the impacts on the economy and how to manage all that. That's way out of my lane. When you come to me in the hospital, I want to try to keep you alive. I want to prevent death, and I want to prevent the massive uptake of ventilator and ICU resources. I know I can do that. But you need to come to me, and I need to be able to use these medicines early and powerfully. I do what I do. I mean, I live in ICUs. I know how to take care of critically ill patients.
We'll come back to you. So two other, hopefully, quick questions. And again, I get rid of your little hand because I want the person who really thinks they can answer this. New York City. What was so unique about New York City? Why did it explode so much? I saw Mr. Roy raise his hand right off the bat there. Mr. Roy.
Yeah, Senator. So there are two. We have, of course, don't know for sure, but we have evidence about two things. One, a group of economists at MIT traced subway stations in New York City to certain zip codes where there were outbreaks and found a high correlation. So there appears to be a lot of correlation between the use of the New York City subway system to outbreaks of COVID-19. The other piece that's really important in New York State, which affects New York City as well, of course, is New York State and New Jersey both had policies of requiring that nursing homes accept patients who were discharged from the hospital with COVID-19, even if they still might have an active infection. And that may have contributed to the outbreak of COVID-19 in nursing homes in those states.
Okay, and so I'll take that as the answer. Again, if you want to refute that, it's in the very last stage of questions. My last one is the stated policy of all these, economic shutdowns and, safer at home policies, that type of thing, was to flatten the curve so we don't overwhelm our healthcare system. But in flattening the curve, is that any guarantee that will actually reduce the ultimate number of infections or ultimate number of deaths, barring a cure? So who again? You still some. Anybody want to really take that one?
Yeah, Senator, I'm happy to address that. And I think in our discussion, I mentioned that I've been privileged to work with a number of experts in mathematical modeling, and in particular, I can cite a paper by Maria Cecchina at the University of Pittsburgh and Wes Pedgin at Carnegie Mellon. They worked collaboratively and published a pop culture piece calling for honesty in pandemic modeling. The problem with an interdiction strategy that starts and ends with flattening the curve is you can never stop. Everybody's been kept away from the virus. Everybody's been sheltering in place. Nobody has immunity. And so if there's any level of viral circulation, asymptomatic carriers, for example, everyone remains vulnerable. The minute you release those clamps, you get the spike you thought you had prevented. You just make it happen on a different day. So flattening the curve makes good sense while you devise a strategy for the next phase. And again, I think most of us collectively are arguing for that transition to a phase where we risk stratify, get better data, identify who's at risk, protect them, but allow for viral circulation in the portion of the population at very low risk of needing a hospital bed or getting very sick. But if all you do is flatten the curve, you can never stop. You can never stop until, for some reason that you don't necessarily understand, seasonality, the virus goes away, maybe to come back, or you not only have a highly effective vaccine, but mass produce it and give it to everybody, or you have to allow the virus to circulate and those who can safely get through it to develop herd immunity. But that's the problem with flattening the curve. Absolutely a critical tactic to avoid overwhelming a medical system at a given place in a given time, but it really can only be phase one of a multi-phase plan.
Okay. So I'm glad to see Senator Rosen came back. I'll switch you over to you, Senator Rosen. Then to close out the hearing, anybody wants to stick around, I'll go in reverse order and just, you can make your closing comment. But to Senator Rosen.
I think I'm unmuted. Can you hear me? Did I do the right thing? We can hear you,
yep, loud and clear.
Perfect. Thank you. Well, thank you for having this hearing. I want to thank the witnesses for being here today. I do want to mention before my question that Senator Rubio and I have requested a longitudinal study on COVID from NIH and CDC, that a 10-year study to be reported initially every 3 months, 6 months going forward. I do believe that that will help us. That data will point us in some direction as to what policies work and where we might need to fund or put our efforts going forward. That data is very important. I hope to be doing some more studies. I think the data matters and can really, like I said, point us in the right way to policy and legislation. Today I want to talk about worker safety. So Dr. Inglesby, I want to ask you a question in your capacity as someone on a recovery team. You know, you're charged with helping a governor reopen the economy of a state. A big part of reopening, of course, is the workers returning to their physical workspaces. So in Nevada, we are known, of course, for a hospitality industry, from Lake Tahoe to Lake Mead, Reno, Las Vegas, hotels, gaming, entertainment, outdoor tourism, everything in between. And our hospitality workers can't do their jobs remotely. They are all so eager to go back to work. And some are concerned that not doing it, that they might put their families at risk if they do return. So what can you recommend to the hospitality industry, which is a huge portion of Nevada's base, as they reopen slowly in the coming months? What are our best practices for hotel rooms? And we want to protect our workers and our tourists that come. So how do we balance that? Customer safety and employee safety, because we want everyone to come back and enjoy their Las Vegas and Reno, their conventions and vacations.
Yeah, I mean, I think the tourism industry is probably one of the most challenging industries to consider as we think about reopening, given the density of many of the activities and the closeness of people interacting. I think my understanding is that the travel industry is really also seeking lots of guidance from the federal government about what would be the most safe practices. I think those practices will include things like trying to increase spacing in places where people are gathering, which will be difficult, especially in many of the settings that you just mentioned. They'll talk about, for hotel rooms and things like that, terminal cleaning of hotel rooms that's much more intense than you might have considered before. Giving employees personal protective equipment where relevant. I think it's one thing to consider the customer that's coming into a facility, but I think the experience of the workers there, where they're actually on the receiving end of lots of interaction, I think they have special concerns about not getting infected on their jobs. And then information to employees and languages that they speak in so they understand the low bar, or when they have a range of symptoms that could be COVID, and getting very early medical intervention, and the possibility of including testing in some of the regime, or the workplace, either return to work or regular testing on the job, to make sure to give people confidence in those workforces that there aren't people who are sick at work. I think I hear many employers asking about the possibility of testing in those settings. So that combination of things, and then I think it will be useful for that industry to have guidance from the federal government that they can lean against and say to both their customers and to their own employees, we have done what the government believes is the most safe as we've reopened.
Thank you. That was actually my next question. What role does the federal government, because we have so many of our companies, they want a clear standard for everyone to kind of follow as best they can, at least a broad standard. And so I think that is our role, and it is really important that we have that basic standards to meet. You know, we've also been focused, of course, in Nevada, not just our tourism and the Las Vegas Strip and up in Reno, but we have a booming outdoor tourism. If you've been to our mountains and Lake Tahoe and Lake Mead, and skiing and hiking and biking. But indoors is one thing for our hotels and conventions, but what do we do about our outdoor tourism, or even our restaurants, things that can move outdoors with natural ventilation and no enclosed spaces? What kind of protections or guidance do you think we need there? Of course, it's going to be a little bit different. I want to be able to speak to our businesses that are in that outdoor recreation space as well. And what can you tell me that you think we need to do there, kind of direction?
Well, I think what we know so far from studies, especially studies from China, but other places as well, is that outdoor infections are much, much less common than indoor infections with COVID. So outdoor spaces will be safer and will have less risk than
maybe just the mask
environments. So yeah, when people are in close proximity, then masking is important, but then keeping people space, if possible, when they're outside together, unless they're with people that they live with, that would be a safe practice that people could probably do in many of the outdoor environments that you're talking about.
Thank you. I think I have one more question for you on therapeutics and testing. And so would you discuss in just the short time we have left what markers we need to reach regarding effective therapeutics that are widely available to treat the more serious cases before we're ready to fully lift those stay-at-home orders? A lot of the people that I talk to, whether they're business owners, friends, family members, members of my church, community, they don't feel safe to go back out because they're worried that there isn't any treatment for them. They're not thinking even about a vaccine, that if I go, there's no treatment to make me better. And so can you talk a little more broadly about the markers we might need to reach on that, on therapeutics before people can feel safe?
Yeah, unfortunately, I think it's going to be difficult to get to those markers sometime soon. I think there are a number of therapies that are in development and they should be studied. You know, I think there are very sophisticated trials going on around the country and people working on those issues with NIH and independently. But I don't see, even remdesivir, which did have a promising result, it isn't going to make them safe. It's going to make them get out of the intensive care unit perhaps a bit more quickly. but we don't have a medicine that's close on the horizon that is kind of a cure-all. So I think for people who are at high risk, older people or people with underlying conditions, at this point, if there's community spread in their community, and in many places in the country, there do continue to be a number of cases in those states or those communities, then I think there is a level of risk to being out and interacting. There are places in the country where the numbers have come down very low, and that would be different in those places. But I think for people in communities where there is community spread, I don't think we're going to have a therapeutic solution anytime soon. I hope we do, and there's things that are being studied, but I don't think that should be probably a marker for reopening broadly, because I don't know that we're going to get there.
Thank you. I appreciate your time.
Well, thank you, Senator Rosen. Sorry we missed you your first time around. So here will be the final round. We'll go in reverse order. I would ask you to keep your comment relatively succinct. If you can do it a minute, I will interrupt you probably around the 2-minute mark, but try and be respectful for the other witnesses' time. Again, I just want to thank all of you. You've hung in there. You've been incredibly patient. I warned you all this would be frustrating. But again, this is, I think, incredibly valuable testimony from everybody. So we will start with Dr. Atlas.
Yeah, just thank you very much for allowing me. Thank you for allowing me to participate. I just want to make sure everybody understands we're not at the same place we were when this all started. We have learned a tremendous amount. We have a tremendous amount of evidence. We don't need at this point to start doubling down on hypothetical models, because we have empirical data. We have decades of established medical knowledge, and now we use logic, applying the data. We know who to protect. We know who's not at risk for hospitalization and who is. And we need to make those protections very strong while making sure we're not interfering with the actual pathway to establishing population immunity and safety. And that is the idea of allowing low-risk groups to set up these immune-based population immunity result of so-called herd immunity. There's artificial barriers being set up that are obstacles to ending the massive destruction from total isolation. We really need to be very cognizant of that. A strategy of stopping COVID-19 infection is not an appropriate strategy.
Thank you, Dr. Atlas. Dr. Ioannidis.
To be this hearing, I really feel that I learned a lot hearing to colleagues and also getting some excellent questions from senators. We need to realize, as Dr. Atlas said, that this is a crisis that we have almost gone through, at least for this season. And even though we lost many lives, we have every reason to be optimistic. We know very well who are the people and what are the settings that we need to protect. We can reassure the vast majority of the American population that their risk is extremely low, in the range of other activities that they do routinely every day, like driving a car. They do not even give a second thought of whether they should do it or not. At the same time, we know where are the devastating settings. We know that nursing homes, we know that hospitals with nosocomial infection, we know that particular occupations are susceptible to outbreaks, and we know how to protect them. We know how to focus our efforts in securing a safe environment in these places and not allowing major outbreaks to happen. I'm pretty optimistic that we need to move forward with relieving shelter-in-place orders and lockdowns, because currently the risk-benefit balance is clearly against their continuation, even if we get a resurgence of a second wave by lifting some of the measures. We need to try with science, with continuous feedback of information on incidence and prevalence and bed capacity, but hopefully we will do very well. And if one of our steps is not the one that we should take, we can always backtrack and correct it.
Well, thank you, Dr. Ioannidis. Mr. Roy.
Thank you, Mr. Chairman, again for having us all here. And I want to emphasize that the detailed version of our plan is at freeop.org. I'm more than happy to brief any members of this committee or staff on some of the recommendations we have for Congress on how to reopen the economy. A question that came up in an earlier part of the hearing was, why is it that New Zealand and South Korea and some of these other countries have done well? I want to emphasize this. They have very disparate or heterogeneous reactions from a policy standpoint, very different healthcare system. the common element in all those specific rim countries is they dealt with SARS-CoV-1 in 2003. And that meant the populations, as well as the policymakers, knew how to react to this serious threat in a way that those of us in the West did not. And I think that made the biggest difference in their ability to get out in front of SARS-CoV-2 and COVID-19 in a way that I think a lot of us haven't appreciated. And that leads to this point about the second wave. There's a lot of talk about a second wave. We should remember that there was no second wave with SARS-CoV-1. SARS-CoV-1 happened, and then it flamed out. Those economies bounced back in about 6 months. And then people still remained scared and alert and wore masks to work when they got sick. But life eventually did return to normal without massive testing regimes, without a cure or a vaccine. Mention Sweden very quickly. Sweden is a model that I think we should look at more closely. The one thing that we can improve on relative to Sweden, though, is they did not do a good job of protecting their nursing homes. A lot of their deaths proportionally have happened in nursing homes. We can do a lot to restrict visitations and make sure that staff stay local within a particular nursing home, don't go to multiple nursing homes and spread disease that way. Finally, I want to mention the fiscal crisis. We haven't talked about the fiscal crisis at all that has come out of the economic crisis. We've spent about $4 trillion and increased the debt. As you all know, that is a huge long-term national security problem, along with everything else that a fiscal crisis can be. That is what increases the urgency of getting the economy back in place, because the more we accelerate our fiscal crisis, the more long-term problems we have across all the things that Congress has to think about. Thank you again very much.
Well, thank you, Mr. Roy. Dr. Inglesby.
Yes. First of all, thanks so much for having me today. I really appreciated this discussion. A couple of points. The first is that there's been some discussion about how this disease might be already widely prevalent in the United States. I don't agree with that. I don't think we have evidence for that yet. It may prove to be the case, but at this point, I think the evidence is more consistent with single-digit prevalence in the United States. And that relates to the second point, which is it seems like some of the other witnesses are encouraging us to move towards a herd immunity strategy. And I just want to lodge my disagreement with that strategy. I think it's pretty clear that we need to get up to 70% or more of the population to begin to develop herd immunity. That is a long way from where we are now, which may be as low as 3 or 4% in much of the country. We've had 70,000 deaths from this disease with seroprevalence, which I believe is low. We'll find out when studies get better. So I don't agree with that, and I think that would be dangerous. I think it's also dangerous to say that young people are at zero risk of this disease. It's true they're at much, much lower risk, but we are seeing young people get strokes in New York City. We do see some young people that are quite ill from this. I'm not saying it's a grave threat as compared to other threats, but it's also not correct to say that there's zero risk to young people. And then the other thing people have been talking about is whether there will be a new wave or not. And we're already still in the middle of a rise in cases in this country, and I don't think it will be the fall before we have further undulations of cases across the country. I think we're at risk of having small waves throughout the summer. I don't see any evidence yet that there'll be major seasonal change. I hope there is, but we haven't had strong evidence of that. So I think we should be prepared for recurrence of cases in the summertime right now as people begin to do social distancing changes. I am in favor of easing social distancing carefully in places which are ready for that. But in general, I don't think there will be a normal economy when people feel and see that cases are rising around them until they feel like there is control of this epidemic. And I think the way to get control is through diagnostics, hospital capacity, and contact tracing.
Thank you, Dr. Inglesby. Thank you. Dr. Katz.
Well, Senator, thank you so much for including me. I've appreciated listening to the questions, listening to my colleagues. I think there's a lot of agreement. In particular, I think we would all agree we do want to minimize the total harms of this, even if there's some disagreement so far based on the best ways of doing that. We've also posted a lot of materials online at my nonprofit, truehealthinitiative.org. We have risk models. We have arguments there for this total harm minimization approach. And I think it allows for a range of opinions about what's the best way to get there. I largely agree with my colleagues that we have the needed information to risk stratify the population, but I would argue it's crude risk stratification at this point. We know elderly people with chronic disease are at high risk. We know young, healthy people are at lower risk. But is a 40-year-old with mild obesity or mild hypertension at higher or lower risk than a 50-year-old without those conditions. There are a lot of combinations where I think we really do need representative random sampling. So a particular plea to you and your capacity as chair of this committee that the federal government implement a policy of representative random sampling. We don't need millions of tests. Let's do 50,000 tests, but let's make sure we do them in a population that represents all of the United States. Second thing is we do need a health promotion campaign because we can't modify age, we can't modify sex, but we can modify many of the chronic disease risk factors and many of the lifestyle practices that are influencing the acute risk for COVID. So these chronic liabilities that really were a huge drag on health and vitality, and for that matter, the economy in America all along, are now an acute threat as well. And I think part of the return to normalcy policy ought to be, we're going to help everybody get healthier. So you actually come out of this stronger. There's an acute benefit, there's a lasting benefit. So those two requests really for the federal government, representative random sampling, so we're flying through a less dense fog, and a nationally coordinated focus on helping to alleviate the burden of chronic disease that is now an acute liability too.
Thank you, Dr. Katz. Before we go to our final witness, I just want to point out, I was the guy that championed right to try. I'm a big believer in letting doctors be doctors to practice medicine. There's nothing that is universal. And certainly in this case, one of the reasons I've been pushing that so hard is an effective therapy, an effective cure will break the back of this disease almost overnight. It'll end the economic crisis. And so that's why I really did invite Dr. Kory, because I was very encouraged by the work he and his colleagues were doing once people became hospitalized. But again, I really want to make sure that we're also pushing the envelope, allowing doctors to prescribe off-label. Let's not restrict their use. It's what we've done with hydroxychloroquine. Again, I don't know that's going to for sure work. There's an awful lot of anecdotal evidence. But again, I really want to make sure that we continue to support doctors like Dr. Kory and others that are, again, practicing medicine, exploring different theories of this case. The sooner we can end up with an effective therapy or a cure, again, we break the back of this disease, this crisis, this horror almost overnight. So again, turn it over to you, Dr. Kory. Give us a little bit more hope and keep practicing medicine.
Yeah. No, thank you, Senator Johnson. And you and I have an affinity on this. I totally agree. The gloves need to come off. This disease is wicked. It's really, I get confused when people are comparing this to the flu. I've been a doctor in an ICU for 15 years. There's nothing like this disease. Let's stop comparing it to other ones. I have patients filling ICUs with fibrotic lung disease who I cannot ventilate without deep sedation and paralytics because their lungs are destroyed. This is not what the influenza does. This is a completely different disease in the sense that its acuity, its severity, and its rapidity is unlike any other that I've seen. It doesn't mean I can't handle it. I know I can treat this, but you got to let me do it. We got to get it earlier. My problem is that everybody looks at the ICU doctors to solve this. It's not the ICU doctors. We just need to move more powerful therapies a little farther out. We need to get it in the ED and the hospital wards. I promise you we can avert this tragedy of fibrotic lung disease and ventilators. I know we can do it. We need to have a much more robust treatment strategy. The other issues, I got to say, I totally agree with Dr. Inglesby. Again, I don't want to be outside of my lane, but like the prevalence and this herd immunity stuff, I don't know about that. That's not what I'm expert at. I get the whole thing about balancing between saving lives and continuing life, which is economic activity and financial activity and all of that. I don't really know the answer to that, but I really do believe that if we can find an effective solution to prevent the deadliness of this disease, it would mitigate and it would help everything else. And that's what I'm just trying to promote. I think we can do this. We have effective therapies. I'm getting increasing reports of really good responses to treatments. And like you said, Senator, we just need to be able to treat these things. Everybody has to stop thinking that we need to do everything in randomized controlled trials and this is experimental and dangerous. We know what we do. And I don't know, if we come up with an effective medical therapy, this would mitigate a lot of the harms of everything that you guys are talking about, which is opening or closing or not. I just got to say, I'm a doctor. I work in a hospital, and I really believe that the world needs to think about and the health societies need to think about what they're proposing for treatment. I really think we got this wrong. We got to be stronger, hit harder, faster, and earlier, and we will do better. This will change the economy. That's all I'm saying as a doctor.
Well, listen, I appreciate that. I am so afraid that we're letting the bureaucracy. Again, these are good people. They're trying to do the right thing. They want to have safe drugs, but
agreed.
We have safe drugs. You can let doctors practice medicine, use off-label, explore different theories of the case, develop that therapy. And to me, that is the solution. It'll be available hopefully far sooner than a vaccine, which may never come, which has also been brought up in testimony. So again, I want to thank all of you for your patience, for your testimony, for what you're doing, for being a doctor, for saving lives. God bless all of you. The record will remain open for 15 days until May 21st at 5 p.m. for the submission of statements and questions for the record. This roundtable is adjourned. God bless all of you. Take care.